Let us invoke Goddess Saraswati by lighting the lamp of knowledge and Saraswati Vandana to be sung by Miss Niyati Magan, MPhil Clinical Psychology trainee. I request all the dignitaries present to join in lighting the lamp, please. अच्छा दरवाजा लक्ष्मी दरवाजा बंद करवा दें हाँ हाँ सर We also have the blessings from our respected founder president, Sir Dr. Ashok K. Chauhan, Honorable Chancellor Sir Dr. Atul Chauhan, and Honorable Vice Chancellor Madam Professor Dr. Balvinder Shukla. Niyati, please start with your Saraswati Vandana.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शङ्करा प्रभृतिः देवै सदा वन्दिता सा मां पातु सरस्वती भगवती निशेषजाड्या पहा सा मां पातु सरस्वती भगवती निशेषजाड्या पहा शुक्लां ब्रह्मविचारसार परमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदाम् जाड्यान्धकारापहा वीणापुस्तकधारिणीम् अभयदाम् जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने स्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदां. Thank you.
Thank you, Niyati. Now, I would like to invite Professor Dr. Rushi, Director IBHAS, that is Amity Institute of Behavioral Health and Allied Sciences, to mark the beginning of this national seminar with a welcome note for the participants and speakers. Dr. Rushi, please. Our Honorable Vice Chancellor Ma'am, Dr. Balvinder Shukla, and respected Dr. Bandyopadhyay Sir, Chairman, MET Law School and Chief Advisor, MET Group, respected and our mentor, Dr. S.K. Srivastav, who has always been the driving spirit for all of us, and distinguished dignitaries, especially Dr. Sujata, Professor Dr. Sujata, who has done so much work on trauma, and we are blessed to have her today in this session. Dignitaries, all the participants, guests, very good morning to all of you. I welcome you all today on behalf of Aabhas MET University, Noida campus, to this national seminar and CRE program on trauma-informed care. We are honored by your presence. As we know that the repeated exposure to trauma, whether it is emotional abuse or it is physical or sexual abuse, violence, or any adverse event that impacts the mind, that impacts the brain, and literally that affect us in such a way that we are struggling with the issues of emotional regulation. It affects our response to emotion, and that's why we are having the problems of anxiety, depression, or substance abuse. Trauma survivors are often at risk of chronic physical illness, behavioral health issues, and even suicide. So knowing all this, I believe often we should there is need to change the approach, there is need to change the perspective to care. So there are very simple ways every healthcare organization may gradually integrate. We can integrate the trauma-informed care to already existing practices, what we are going to learn today, right? And not only the healthcare organizations, I believe, every teacher or every school, every college, and every university should integrate the trauma-informed approach to their practices and while dealing with the students, right? The training should be provided to those who are basically suffering with trauma, and not only to those. I believe the training should be provided to all the teachers, the faculty in the university, because teachers are the one who are handling the students directly every day, and they are having an impact on their mental health and their socio-emotional development and well-being. Training should be imparted not only to the clinical staff, it should be imparted to the non-clinical employees also, like the front-line workers, the security guards, who are often the face of any organization, right? So training should be imparted to teachers as well. That's how we can maintain that approach, and that's how we can integrate that approach into our clinical practice. We need to create an environment which is safe and which is welcoming, not only to the patients, but also to the students and staff in your organizations. All the healthcare workers and educators need to identify and need to address trauma effectively, considering the screening approach, which works to assure you that in your organization, in your institute, the treatment and the referral sources are available. So trauma-informed care can truly transform us, or it can truly transform the caregiving approach from being treatment-centric to trauma-centric. Healing-centric. So that's what we need to integrate, and I hope that this seminar will help equip us with the knowledge and the practical skills we are going to learn in these 2 days to provide more compassionate, more resilient, more sensitive, and more, effective support to the survivors. And by prioritizing trauma support, we can create a healthier and sustainable society. And I really want to congratulate all you, and I really appreciate the participation. We have more than 200 registrations for this trauma-informed care CRE program. So at that, I had to stop the organizing team that, for the quality assurance, now we can have more than 200 registrations. So that also shows the, need to look into this domain, into your clinical practice, and you people are giving so much importance to that. So thank you so much for your participation today in this national seminar. Thanks a lot for your presence. Thank you. Thank you, Dr. Rushi, for the warm welcome address. It has set the right tone to begin the day. Next, I would request our mentor, Dr. S.K. Srivastava, sir, Senior Director, Vice President, RBEF, and Advisor at FPO, Head of Amity Foundation for Developmental Disabilities. He has devoted his entire career in the field of disabilities and is a well-known figure. Has spent more than 35 years on various senior positions in the field. So, kindly share a few words of wisdom with us.
Thank you, Dr. Rashmi. Respected dignitaries on and off the dais. Very good morning to all of you. I say good morning. Thank you very much. So you must be awakened with us. This is CRE program, and in the morning it should not be so silent. I remember that during my tenure in RCI, this CRE program was of so much use. It was offline. People were in the queue to get CRE program, to obtain the number and get their credentials done after 5 years, 100 points, how to acquire 100 points. But the silent feature of CRE program, you all know, that it improves your, upgrades your knowledge, not only improves your credential, but also upgrades your knowledge. So my humble submission and suggestion to all of you is that while during presentation, you listen very carefully, but don't make any session one way. When the presentation is over, unless you put your queries, you remove your doubts, whatever it is, either you contribute something more to the topic, or you ask some doubts, whatever is with you, so that it becomes not only interesting, not only interacting, but also your question can supplement to many of other participants who will be clarified on the issues. This is not a very technical topic. You all know how to take care of the traumatic conditions. There is a complete field of oncology in the field of psychology. Likewise, trauma care. I was asking Dr. Rushi, what is trauma-informed care? What is informed? Is it earlier informed? Then she taught me what is trauma-informed care in the evening. Then I understood how useful this topic is. So, friends, I'm really overwhelmed and very happy, and is again welcome all of you on this Amity campus. Such a huge crowd. It gives us so much pleasure that you cannot imagine how we are so happy, and we'll be enjoying your company for 2 days with us. You also enjoy with us. You visit the Amity whenever you find time. Enjoy your interactions, enjoy your sessions, and have a nice day. Thank you very much.
Thank you, sir, for sharing your address and your thoughts for participants. Moving on, today we have with us Professor Dr. Dilip K. Bandyopadhyay, who is a visionary leader in India's education community in modern times. A gold medalist in his master's degree, a PhD in computer applications, a fellow from ESSEC Business School, Paris, and an inspiring professional, Sir has spent 40 years of his career in academia. He has more than 70 research contributions and has addressed various Indian and global management students in various countries, notably Canada, France, Germany, UK, Sweden, to name a few. He is a fellow of All India Management Association and the Institute of Electronics and Telecommunication Engineers. Sir, kindly enlighten our participants with your insight from your vast experience, please.
So at the outset, I must congratulate to all of you because you felt the need that you should come and attend this continuing education program. That's the most important thing. I must thank Rusi. You are very new to the system. Very new to the system. I don't think you have spent more than 4 months or 5 months.
3 months.
3 months. Not even a quarter of a year. Now, type of vibrancy I could see that she is bringing, it's overwhelming. Bringing all of you together at one place, putting her efforts for doing that, it speaks her dynamism, her foresightness, and the way she wants to build up the institutions. All my congratulations to you, Dr. Rusi, and I hope you will continue doing such type of activities with the mentorship of Dr. S.K. Srivastava ji. Today we are honored by the presence of Satpathy ji, very known clinical psychologist and working at All India Institute of Medical Sciences. And, all of us know, and I have been told that you are a child psychologist. You take care of the children, which is the most difficult proposition. And now, certainly, Dikshantji, you build up this institution. All of us build institution. Then we hand over to our, juniors. The juniors become senior. They again hand over the institutions and they go for some other job to do.
Clap for sir.
Now, when I say that trauma, I was not knowing my Rusi मुझे बताया नहीं कुछ. She did not tell me anything. मैंने कहा भाई I am not a psychologist. तो मुझे क्या पता है trauma होती क्या है? तो anxiety तो होती है, क्योंकि मैं 3 times वाइस चांसलर थे. तो 3 times जब वाइस चांसलर होते हैं तो उसको तो एंजाइटी हुआ करते थे. तो वो सबसे ज्यादा एंजाइटी था हमारा इंद्रप्रस्थ आईपी यूनिवर्सिटी में. आज द वाइस चांसलर आईपी यूनिवर्सिटी. तो पता नहीं हाउ मेनी ऑफ यू हैव पास्ड आउट फ्रॉम देयर. आई डू नॉट नो. You have passed out. How many of you have there would be many. So all of you, there was no pressure from the student side, but there is to be pressure from the faculty side. And there is to be pressure from the government side. इसको admission करा दो, उसको नौकरी लगा दो, उसको ये करा दो, उसको वो करा दो. So tremendous amount of anxieties and stress. But I made a one policy because that could be one of the therapy. That therapy is build the rule, follow the rule. Build the rule, follow the rule. President's house, I am sending this person, please appoint him. So then I said, yes, I will appoint. But please give me writing that I am directing you to appoint him. Never he is to come back. Never ever he is to come back. So what I am trying to say, stress management, most important thing of today. And 1990 when Freud, he proposed this theory. And after that, it has again developed leaps and bounds. This concept of management, trauma management, has taken its different shape. Now, previously, what wrong with you used to be the concept of understanding as a therapist. What is wrong with you? But now it has been transformed to what happened to you. What has happened to you? That itself, if we just expand these words, it will take you to a different echelon. And this dimensions as a therapist, all of us are to understand it. Because the way things are developing, because we are student of mathematics, because psychology is very attuned with mathematics. That's what I see. You cannot do anything without any statistics. You cannot do anything without model building. So if we just look at the way the psychology is developing, nowadays the buzzword is positive psychology. How do you really become a positive psychologist? What do you understand by positive psychology? How to create the learning mindset? How to create the growth-oriented mindset? These are some of the topics, new topics that are coming up. Now, the moment we put them all together, there's a new way or new therapy should emerge at, because 1990 and 2023, there is a vast differences. Being a student of mathematics, we all know that no two individuals are same. Their genes are different. Their environment, they have grown up, that's different. The educational system, they have gone different. The parents are different. So if we apply the same theory or same therapy to everybody, it does not work. So trauma itself, if you just look at the emotional response to a terrible event like an accident, rape, natural disaster. It's like say Himachal Pradesh, all of a sudden people are sleeping in their home. All of a sudden the water gushed in and the home washed away. Now look at the trauma of the survivor. Many of them have died, so we can't do anything. Only God can take them to rest in heaven. But those who have survived, can they forget this trauma throughout their life? So it will reflect back all the time. When the COVID started taking place, now all of us are the victim of those trauma. We are not able to go out of my home. We are confined for about 2 months inside the home. That's all the time a fear. I could see my neighbor, somebody is dying. That trauma still is carried out. Now what do you do about it? And all of you who are trained clinical psychologists, what is the new method, new therapy you will design by yourself to apply to individual, not team or group or collectives or the community? There may be similarity of the community, but again, individual to be treated individually. And that is the way how I look at it. That is the way one day I was talking to Rushi. Rushi, can you just see, can you apply me this, transaction analysis on me? I like to understand what are my weaknesses, what are my strengths. Can you tell me? Well, sir, I will do it one day, but don't cry. Because I have seen those who are undergoing this transaction analysis, they all the time cry when they know the type of person they are, the type of things they have done, the type of thing they should not have done it. So again, what happened to them? What happened to them? How they understand what happened to them? The moment they understand what happened to them, then they will be able to develop themselves to take care of this trauma. I think this is a great efforts made by organizing team. But who are there in the organizing team?
The first of all, Dr. Rashmi, she is the coordinator.
Rashmi is the coordinator?
Yeah.
Then?
And the whole team.
Whole team, name? Sneha? Prerna? Anybody else? Deepika? Jassi? We feel so proud of you. We feel so proud of you because you felt like there is a tremendous need for this topic to be deliberated for those who are practicing. We teach to the freshers. We groom them to become a professional. But they are already professionals. Now, having a discussions and deliberations for the professional in the continuing education, it demands already Mentor Saab, Dr. Srivastava, very eminent personality in the field of rehabilitation sciences. He has maintained he has mentioned that don't allow, because it's not that you are in the classroom. You are in the training program. So you will have many things you will maybe knowing. Something will be discussed. Now try to get into the deep of the subject, ask questions to deliberate, so that it will be helpful to others also. And then the training program will be successful. Otherwise, somebody will come and deliver for half an hour. Some of you will be sleeping. Some of you will look at the mobile. I just see that she's looking at the mobile. And some of you will chit chat, gossip. Some of you will, "Arey kya ho raha hai bhai? Ye kya topic chal raha hai? Mujhe to already pata hai." But what I'm trying to say, the actual benefit you'll be earning if you make it a dialogue-based discussions, deliberations. And my request to all of you, make it interactive. Make it the way you feel that your value addition is going to take place. 2 days is a very important time for all of you. And that 2 days should be fruitfully utilized. I mean, that is the way I convey my feelings. And all my congratulations once again to all of you, because you decided to be here. Because nobody has forced you to come over here. You have decided to come over here. That means you want to learn something, what is happening in my profession, what is happening, what is the new theories or new therapies that are in the offing, or how my contemporaries are looking at these issues from their perspective. Can we share among ourselves and can develop the best practices? Then it is going to be a successful training program. So thank you very much. Thank you, Rusi. I don't know why you invited me, but as you called me, I could not say no. And I know that Srivastava ji is behind you. So if I say no, that means I'll be saying no to him also. So which I cannot afford to do that. So thank you very much.
Thank you.
You have given such a good start to the whole program.
For that only we invited. Clapping more than once. Right, thanks.
Thank you, sir. Thank you for setting the agenda. Thank you so much, sir, for your encouraging words and valuable inputs. Now, I would like to invite our ex-director, Professor Dr. Dweepchand Singh, sir. Sir has been associated with Amity for more than 16 years now, and sir has keen interest in research, and he has numerous publications both in national and international journals to his credit. Sir, kindly share your views.
Good morning. Those who are in Delhi, they might be knowing there are 2 centers, trauma centers. Anybody can tell me where are those centers? Pardon? Right. Another one? Other one? It is near Safdarjung Hospital, but it is run by AIMS. So the history of those centers is entirely different, and it is meant for physical injuries on roads or somewhere else. Trauma means, usually we understand that trauma means physical injuries. And first and foremost, now in medical practice, which has been abandoned or stopped, that is the forceps deliveries. If you have seen or any trauma received child head injury that time, now it is medically stopped totally. First trauma a child or any individual can receive any trauma, that is at the time of delivery. It is stopped. And the consequences of the trauma, head injury. This you can read in books what was there earlier. Now, these are the physical injuries to body, to brain, and to self. And when this trauma to self is there, and then we psychologists are concerned with that. If you remember, in 60s, there was a topic came culture shock. And for that, people started training. If you go to some different country, different culture, and there was like this training that how you will see. Especially it was from developing countries to developed countries in Europe. And they said that, yes, that will be there, that all activities, sexual activities, you can see anywhere in park, anywhere. But to my surprise, I didn't get shock in London. I didn't see any activity there, except just hugging in front of King George College. But in Delhi, in metro, yes, it is there. But who gets shocked? Probably nobody. But when we talk that, yes, childhood trauma, and trauma doesn't have any limit to age or any section of society. Trauma can be inflicted by man-made or nature-made ways. What was the tsunami? Long back we got. Long back we had a Bush earthquake. Yes, we had trauma there. So the trauma, it is not only that we get in, say, sexual abuse or physical abuse or something abuse. It may be in office also. It may be anywhere, or it may be some worship places or education places. But how we receive that, I call it just event, undesirable, unfavorable event. I'll give one example. You have seen egg, you have seen ghee. When it boils, one melts and one gets solidified. Any event in our life can direct or redirect our ways of working or facing the situation. As our Prime Minister usually says, कि हमें आपदा में opportunity ढूंढनी है. How many we learn that thing? It comes from very beginning, childhood, that how parenting, I'm coming to parenting. Yes, parents, if they are from same background, but they don't have time, both of them goes to their office work or something else, or like this, who will take care of the child? Or nanny will take care of the child? And how nanny will transfer her cultural views on the child? Or mother comes from different background, father comes from different background, and usually they fight how to parent the child. Again, trauma. So from childhood, and I'll give one example, that many of us are in hurry always. If I ask her, where again? I'm in a hurry, I'm going to there. And is there in fire or there in something like that? And they never reach the target or goal. They are always in hurry. Why it is so? Probably in childhood, not probably, definitely in childhood, they had been traumatized to run fast, to reach on time, to work this, and then they never finished till today. And they always see me, he, she, it, everybody is in hurry. And then if you find that it is some traumatic experience they had. So when we see the patient, I'm coming to patient or clients. If we work in hospital, everybody when gets sleep, he becomes patient. And now some people from America or other places, they started, no, he should not be called a patient, he should be called a client. Okay. But how much difference is there? The trauma goes down if we say patient or client. We have to see. So we have a spectrum of trauma which we have to learn, whether physical, social, cultural, financial, or natural. And usually we say that emotional expression, yes, it may be. Why only emotional expression? Emotional expression in when we are with other person or persons. But when I'm alone, I'm crying, I'm laughing, I'm not doing anything. It is not that. So every activity from childhood to till now, any point of life or time, we can receive unfavorable interaction with the environment or with the persons. And how we receive that, as egg and ghee receive that. Thank you very much.
Thank you, sir, for your valuable inputs. Now, I'd request Professor Rushi and other dignitaries present on the dais to welcome our first speaker, Dr. Sujata Satpathy, ma'am. Welcome, Karim, sir. So, I'll be sharing a detailed introduction of ma'am when we'll have a start with our academic proceedings. As of now, we need to know that she has been working intensively with trauma symptomatology, and she's a well-known figure in the field of trauma research in India. And it's very kind of ma'am to spare time from her busy schedule to address our participants. Before that, I would like all of you to welcome her. Ma'am, it would be kind of you if you can address our participants briefly. Thank you, ma'am.
So very, very, very pleasant morning to all of you. No, I couldn't hear that. Yeah, you must have learned what sir did, right? Okay. So a very good morning to all of you. I'm really honored and I'm really obliged also. I'm honored because of two reasons. First reason is to see so many vibrant, beautiful faces around me. And the second is all young people taking interest in this particular area. Besides these two things, one academic thing, you all are here to learn something about trauma and trauma management. Okay, that's why I'm honored, and I'm really honored to be here, to be a part of this program, and I am my sincere gratitude towards the organizers to make me a part of this particular event. And the second part of it, I'm obliged because the trauma, it's very core to my heart, very, very dear to my heart. I, as a professional, I started working with working in this particular area back in 1999 when Orissa super cyclone happened, right? So you might not have born at that point of time, perhaps. I don't know. I completed my MPhil in 1993 from Jawaharlal Nehru University, and then I was, in fact, pushed into UGC, that lucrative lecturership. Then I left it because it was dry, okay, although it was quite well paying. And then I entered again into PhD, and back there I was very lucky to have a very good and post in IIT Delhi as a counselor. That was the highest paid, even better than the UGC lecturership at that point of time. And I started my counseling clinical experience from IIT Delhi, right? During that time, 1999, Odisha super cyclone happened, and that was my first exposure to trauma, because trauma was never taught in any of our curriculum till that point. Now also I am very aggrieved for all our curriculums, because no curriculums talks about trauma. And traumatic events, they are in and around us, everywhere, wherever we look at. So that was my first exposure. And that was mind-boggling. And since then, I have been working with disaster. Almost I have experienced each and every disaster, small and big, happened in India till 2015. Before that, I joined AIMS. But till that point of time, I was working with National Institute of Disaster Management. So I was breathing disaster management every day almost. So been to almost 25 countries to learn how do they manage trauma after disaster. Okay, so that gave me a very kind of huge exposure to what is happening across the world. And it is not that something was happening in a very huge scale outside India. No, it wasn't. But yes, they were much more serious about the topic than India was, especially as Professor, my sir said, Deepak ji, ki it wasn't there, right? And seriousness about psychology as a subject, psychologist as a profession, right? And their role in all these areas, that was a very new thing. Government had no clue till 1999 Odisha super cyclone. That point of time, it was recognized there is a need of psychologists here. Okay, till that point, no one had any clue. Okay, and then after that, shifting from, I had in fact a lot of community-based trauma management. I'll show you few of the techniques that we found very, very helpful. Few of my papers are published in international journals also, because they are very unique and unique to our situations, our population, and unique techniques, very, very culture-specific techniques for trauma healing for our setup. Because we are a very resource limiting, very, very resource limiting country, very low resource setting. Okay, we can't really afford what is being afforded. What other countries, especially developed countries, they afford to, right? So after that, I, from a large disaster perspective, then when I joined AIMS, then I narrowed myself down to go to a very specific issue, joining this trauma and mental illness, how closely it is linked. Okay, I switched over here just to have a very strong and intense level of research, how this trauma and mental illness and physical illness, they are closely related. And they're very toxic relationship, but they have very strong, very robust relationship between these two, right? Then a lot of exposure to child sexual abuse, adolescent sexual abuse, adolescent pregnancy, right? And then all kinds of, in fact, domestic violence and all kinds of elderly abuse, whatnot, right? So AIMS provided me the platform to explore and immerse in this particular area. Okay, so I'm grateful to all my previous organizations. So I'm happy that up 2018, for the first time, formally I conducted National Trauma Conclave back in 2018 at AIMS. That was the first trauma conclave in India, and I don't know how many of you had joined me there, but yes, few of you had joined me there definitely. And I had 360 delegates other than AIMS people. So it was overwhelming. And after that, it is here, I'm getting 200 specific population which is attending to trauma. So that's why I'm overwhelmed. That's why I'm very happy. I'm the happiest person in this room, right? So my gratitude towards the institute, towards RUSI especially, to make it possible that all young, vibrant people, 200, it's a big number, are here to learn something about trauma. So thank you very much for being here. And thank you, Rusi, for inviting me and making me a part of this particular gathering. Thank you very much. Before giving for a cup of tea and
Thank you, ma'am, for sharing such a lucid understanding of trauma. I'm sure all of us are going to learn a lot from you in the subsequent sessions. Now, we have with us Dr. Kapil Shukla, advisor to Amity University. Sir, kindly share your blessings with the participants. Thank you, sir.
Good morning, everyone. It's so nice to see this hall filled up, this time. And it shows that everybody who's here is very much interested in learning what is going to be taught during this seminar. I had the occasion to serve in the Indian Air Force for about 30 years, and then in the Prime Minister's office for about 8 years. And now I am with the founder president for the last 8 years. What I have seen is that we all grow in life. We grow up, we grow in our careers, we marry, we have children, they grow up. But one thing which always bugs us is that we should be physically fit. And we give a lot of importance to that. Nowadays, everybody is talking of fitness, yoga and all. But we forget that the biggest problem that we are now facing and are going to face in the future is not just physical fitness, but mental fitness. I have seen cases very close to me who are physically very fit, but they have some problem upstairs. And that does not allow them to work or to enjoy life as we all should. There is a lot of talk of mental health, but I don't find much is being done. I don't know why people shirk away from talking about mental health, especially the people who are undergoing a mental trauma or even the family members. There is some sort of stigma attached to talking about mental health, but I think it has to go. My founder president has been in Europe for about 33 years, and he says that, like Europe, we will also be plagued by mental health cases in the future. And that is why in this university, we give a lot of emphasis on training young people how to combat and help people in combating this illness. You young people are the future of this country. You will help in many ways, in your own ways, in helping people to combat with the trauma of mental illness. Traumas can be of any kind. We have trauma centers all over now, but they look after the trauma of the body. But the trauma of the mind is a bigger problem. So I hope from here you will take back good things. You have very senior people who have been working in this field who will address you, and you will go back enriched. Thank you so much.
Thank you, sir, for your words of wisdom. Now, we'll all take a break. Tea is waiting for us. And kindly try to reassemble after 20 minutes. Thank you. The right precedence for the academic proceedings that we are about to have, but still I would like to take this opportunity to formally introduce ma'am. Dr. Sujata Satpathy ma'am has been associated with AIIMS for more than 15 years now, and she has completed her post-graduation from Utkal University, B.Ed from National Institute of Education, Odisha, MPhil and PhD from JNU Delhi. Her areas of expertise are trauma psychology, which includes disaster, physical, emotional, sexual abuse, domestic violence, pregnancy loss and stillbirth, complex trauma, etc. Home and community-based psychosocial trauma interventions, child sexual abuse focused CBT for children and adolescents, ADHD focused cognitive interventions, CBT and supportive psychotherapies for common mental disorders, and promotive occupational mental health. She has numerous publications in various national and international index journals. She's a member of several scientific bodies. I request ma'am to begin with the topic, please. Thank you.
Thank you very much, Rasmi madam. I welcome all of you to this particular session. Somehow I want it to be little more interactive. I don't know how, but let us try to make it interactive whenever possible and wherever possible. And if I can request all of you just to close the door so that we settle down and then we focus. Yeah. Okay. So the purpose of this particular session, I have two sessions, but this particular session will give you a bird's eye view about trauma and various aspects of trauma. So including a little bit of neurobiology of trauma and trauma pathology. Primarily, it will give you a kind of understanding about traumatic life events and how normal individual responds or reacts to trauma, and what are different types of impacts on individuals when they are exposed to traumatic life events, and then what are the clinical symptoms generally or commonly reported. Then, as I said, neurobiology of trauma and a very crisp view on one or two theories. And finally, the difference between trauma focused and trauma informed care for trauma victims. Okay. Before I start with trauma, I want all of you to be little more energized and little bit more focused so that we start trauma. So there is a small exercise for all of you. Many of you might have done this before, but I want all of you to respond to this. Just read it out and do it and let me know the answer. You have 3 minutes to go. You have 3 minutes to go. All of you, may I request all of you to give your kind attention to this particular slide, which is meant to bring your focus to me and to this subject. Do not look for Google, right? I know you are very friendly, but yes. How many of you have read the question? Most of you. How many of you have understood the question? Most of you. Then the results should be here within a minute. Yes? Because trauma is attention, attention, and attention. Focus, focus, and focus. That's it. It's done? It's done, na? Just keep it reserved. Just keep it reserved. It's very easy. Once you focus, it's very, very, very easy. जब हो जाएगा तब आपको लगेगा अरे मुझे कैसे नहीं सूझा. Yeah, keep it reserved, please. Let majority of you solve it. Write down on your notebook. Isn't it very easy? Yeah, it is. Only thing you have to focus. It is so easy. आपको लगेगा मैं कितनी बुद्धू कैसे हो सकती हूँ. ठीक है? Okay, we'll go for the answer. Yes, ma'am. Yes, you. 6 letters means what? So 6 letter means what? What is the catch here? Answer, I'll ask somebody else. You say me the catch. How did you solve it? But they might have, all of them might have slashed 6 letters out, but didn't reach the result. So what did you do? Yeah. Okay, I'll go to her. Yes, madam. Okay. Let's see what is your answer. Yes, madam. You let us know. Good. That is one way. Okay. I think she has another option. Yes, madam. Yourself. Yes, you. Yeah. What did you do? Okay. But did you got 6 letters? 6, I mean numeric 6 letters. Did you got? No. Okay. Yes. Anybody who has a different answer? Yes, madam. It's banana. That's the usual answer. Okay. That's the usual answer. Okay. So you have to cut SIXLETTERS. Right? What happened? Why majority of you could not do it? You have to come out of clinical psychology to do this. Why? This is very important because we have a fixed frame of mind. Okay? And trauma impacts do not, okay, remain fit into that fixed frame of mind as trained clinicians. Okay? We have to go out of it. We have to do and search for out-of-box solutions whenever we are dealing with trauma patients. Right? It has to be innovative, very simple, but methodical, innovative, learned. Right? Okay. So let us come to the basic understanding of traumatic life events. As many of the speakers, many of the dignitaries, they also spoke about it. And Dr. Rusi also gave a very brief but very pertinent, in fact, overview of the traumatic life events. And all of you might be knowing it because it's in news. Why it is important? If you read through this particular slide, Is it true? How many of you think that it is true? Majority of you. Does that mean that all of us, we have an exposure to some kind of traumatic life events with some intensity rather? Okay? And all of us, we have managed it at a local level. That means it at our level. Okay? And that is creative. No clinical psychology curriculum taught you that, but you have already managed that. Right? So your professional training and your own personal experience with such incidents, okay, experienced by you or experienced by somebody you are associated with or dealing with, okay, that is very, very important. अभी तक भी trauma की framework is not very fixed. Evidence are emerging. Okay, and the interventions are evolving. Right? So yes, it is very important because you can spend your lifetime trying to forget a very small incident of your life. Okay? Okay. So when I say trauma, okay, many of you might not be knowing that it has been derived from the Greek word, okay, which means wound. That is why trauma centers. Okay? One of the dignitaries also said trauma, the word started with medical trauma. Okay? Although Webster dictionary tells you about trauma, but it talks of medical trauma. Okay? Later in towards, in fact, although it started back in 1880s, around 1980s, 60s to 80s, that is the period when this term psychological trauma, the trauma can also be psychological. Okay, informally it was there, but formally people have started bringing it into papers, publications, and slowly, gradually it started happening, and it started being associated with disasters, various disasters. First one is with wars, okay, and it is very, very established. There are very, very established center for PTSD for war victims in USA. It started formalizing from there. Okay, and then gradually over a period of years, it has gone into different diverse areas of our traumatic life events. Right? Okay, so that since it has been, the origin is from medical trauma, as it is also a lot of brain imaging studies and biological studies, they have shown that the response to trauma is always biological. First is biological, then it is psychological. Why it is so? Any idea? Anything that you have read? How it is biological? Again, it is very simple. And you have read it. 100% you have read it. The physiological change. Now he has given you a clue. So now it's your turn to tell me. Kahan padha hai? Yes, yes, yes. Stress response. Fantastic. What is that stress response? Can anyone tell me? Flight and fight. Okay. What is that? What is the name of that particular system? General adaptation syndrome. Right? So it is all the more established that trauma, although the term we are using here to refer psychological trauma, the response to trauma is biological, always. Okay, fine. Whenever you have a doubt, please raise your hand so that we clarify then and there. Right? Okay. Now, to define it formally, trauma, because it encompasses a very wide range of incidents, trauma globally, it is defined in many ways. But one comprehensive way how it is defined is that it is an event which has a capability or which has the potentiality to invoke intense stress. So when it invokes intense stress, means it will occur, respond, our body will respond at a biological level. Now you are able to connect it. Okay. Since it is an intense stress producing event, okay, to kind of threat an individual's existence in his or her surroundings. Okay. And it has the capacity to overstrain individuals' existing resources. That means the coping resources. Okay. And it is sufficiently intense, which can defeat your existing defense mechanisms. Okay. And that is why it is said that psychologically traumatic events, they have the capacity to shatter the fundamental assumption of life we have. Okay. Suppose I am sexually abused in my childhood. Okay. Child's perception starts with safety, secure perception. I am safe and secure wherever I am. Mahal mein ho ya jhopdi mein ho. Okay. And the adults, they are there silently or vocally to kind of protect me. And that protection concept, that safety, that security, that protection, that trust, that gets, all these things get shattered when sexual abuse happens to me. For example, we go to a disaster. Okay, if flash flood, although we know that flash flood kabhi bhi aa sakta hai if we are located there, but it can be that horrific. We never knew that. Okay, so it shatters my fundamental orientation to the world. Right? And all the more because it has a biological origin, traumatic life events, they can leave a very lasting effect on the structure and function of our brain. Right? Any doubt, Tilak? As of now? Yeah, please. Very good question. I was expecting that question. Anybody, can anyone tell me? What is the difference between stress and trauma? A very, very fundamental question. Yes, please. Yeah, yeah, could be. Any other option? Absolutely. Yes, yes. We have some other, I think some, here, please. Exactly. Very good. Stress can be anywhere. Even if we are getting married, even if I am absolutely topping the university, then also it's very stressful. Absolutely. Stress is a very, very normal. Without stress, life is absolutely still. It is inevitable, but trauma is not inevitable. Absolutely. And it impairs your functionality. It impairs the brain. Okay. If you go to chronic, intense, stressful life situations, always, that is adverse life incidents, equivalent to traumatic life incident, maybe some of the impacts would be similar to traumatic impacts of traumatic life events. Yes, but here you are considering something which you are dealing with. You have control on. There you don't have any control. Let us consider a disaster, child sexual abuse, a kidnapping, a war, a terrorism. Do you have any control on that? It is impinged on you. Right? Yes, ma'am. Yeah, there is a term. There is a term called traumatic stress. Okay. When the intensity and the chronicity, okay, is very, very, very high, then we call it as traumatic stress. Right? Yes. Does that answer your question? Physiology. Yeah, normal physiology is general adaptation syndrome hai, but general adaptation syndrome mein agar aapki exhaustion stage jo hai, if that continues for a longer period of time, okay, and we'll see that in neurobiology section, ki how it changes, and it changes that frequently and that intensely that it breaks down. Right? Yeah, so it's a wide range of incidents or events or situations which come under traumatic life events, and so it kind of includes disasters, any disaster, including terrorism also, accidents, any accidents, train or road traffic accident or air disasters, maltreatment, which includes physical, sexual, emotional abuse and neglect, which we neglect always. Right? Many of us rather, we have at some point of time in our childhood, we might have been neglected. It's different, we might not have realized it, but all children are not that fortunate like us. Right? Neglect is a silent killer. It's a silent trauma. Right? Which sometimes go under the carpet because of the survival needs, and sometimes we deliberately do not want to talk about it because it questions us as parents, as adults, as responsible citizens of the country. Right? Then bullying, physical as well as cyberbullying. Okay, cyberbullying is much more dangerous because you don't know the person who is bullying you many a times. Okay, and all kinds of violence at household level and at community level, and torture at household level and community or society level, witnessing large number of deaths or due to disasters, for example. Okay, it's very, very difficult for a child to see, even for an adult to see large number of dead bodies in front of you. Okay, and it takes you takes a toll on you even as a professional. Right? So witnessing suicide at home or in the neighborhood. Okay, traumatic grief or separation from the loved ones, and significant family dysfunctioning due to various reasons. Some member of the family who is in fact in the jail, and many other life-threatening illnesses like cancer, heart transplant, kidney transplant patients. A lot of medical conditions are included within that. And if we categorize these very events into different types of trauma, okay, so what would be the possible types of traumas? If I name, let's say, accident, so what type of trauma it will be? Acute or chronic? Acute, okay. And for example, I say that it's a physical abuse over a period of last 5 years, almost weekly or daily basis. So it will be chronic, okay. And if I say that 2-3 traumatic events happening at the same time, then it will be complex, right? Okay. So it's very simple. When I say acute, it is one single episode. Okay, it could be anything. When I say chronic, it is one, but one or more than that over a period of time. When I say complex, two and more than two at the same time happening with a person. Is it possible to, in fact, face sexual abuse in a disaster relief camp? It is. Okay. Yeah. So, as such, there are a lot of cultural variation in manifestation of trauma responses and trauma reactions. So that is why it is generally considered as a multidimensional cultural construct. And since the individual response varies, and individual, in fact, support system also varies. How support system means at family level, at society level, at country level also, political level also. So it all depends that what is your, in fact, bunch of experiences associated with that particular trauma, and to overcome that particular trauma. So across culture, all the research studies, they do agree and they do have a consensus saying that traumatic incidents are that intense that in all cultures it takes a toll on the individuals who face it, and it's a human experience. It is beyond a normal human experience, right? This is the agreement across the globe. Okay, so it could be, you can be kind of directly experiencing it or indirectly experiencing it through even through television. So there was a study back in 2000 what 2011 World Trade Tower कब हुआ था 11, right? So there was a huge series of kind of studies saying that how witnessing the incident through television has impacted people in America. So it is indirect, right? So suppose parents are in a very abusive, violent relationship. It is indirect, but again still direct because it is affecting you directly, right? So generally, exposure to trauma is very common during childhood and adolescenthood. We'll see why that particular phase is very, very important. And almost if you look at the prevalence of childhood and adolescent trauma experiences, globally, it is almost by and large, it's kind of comparable. And it's in fact, if you look at the a study which was done in India back in 2007 by Ministry of Health and Family Welfare on abuse, child maltreatment, almost 58% of the children, they reported some form of the abuse or other, right? And irrespective of sex, okay? And the time period when it the gravity was high, it was almost 9 to 12 years, right? So if it is more than 50%, that's a huge number in our country. Almost 30 to 40% of the population is they belong to this children and adolescent group. Yes, sir. Can also be traumatic, yes. But yes, the nature of trauma and the management will be different. Because many times what happens in this particular condition is a huge sudden loss. Like there was a few papers on the impact of recession. Okay, and recession still is not considered as a kind of traumatic life event, but it is to some extent in absolutely. Yeah, it is, but technically speaking, it is not included within the purview of traumatic life events as of now at international level. And the management will be entirely different. The management is more of you as a clinician, many of the things you may not be able to manage because that is out of your purview. You have no control on, right? Like getting if I look at the immediate solution is to get some work for that person. One is work, one is livelihood. Financial crisis in the childhood, that means, do you mean to say poverty? Okay, poverty is a very significant event. It is considered as adverse life experiences. Okay, this is ACE, adverse childhood experiences, and poverty is the most significant adverse childhood experiences. Yes, sir. Can we? Corona was, yeah, it was. COVID was during the first and second phase, more in the second phase, right? And it is all because almost one third percentage of our population, they had some kind of death in their family, death or severe morbidity in the family. Yes. Yeah. Absolutely. No, as a clinician, you have to first assess it. Okay. And what will be the kind of crux of that assessment? Because you have to define that whether it should be included, whatever problems he has come up with to you, whether these problems are directly stemming from that particular incident, or there are intermediate many more stressful incidents, okay, life situations, okay. So you have to calculate that how much of the reactions or symptoms or problems he has come up to you with, that is that is due to this or due to the life situation. Mm-hmm. Mm-hmm. Yes. Mm-hmm. It's a very close link between when these kind of cases come. Na, first, please assess the attachment styles. Okay, that's very, very important. One is attachment style and one is the family functionality, the functional relationship within the family. Because every family follows, every couple and every family follows a kind of pattern of relationship and pattern of expressed emotions. Okay, and you need to first look at that. Okay, where it is coming from. Okay, so it is very technical because you have to segregate what is coming from trauma, what is not coming from trauma, right? That is very important. And over a period of years, once you start experiencing such patients, you will be able to clearly separate out. And it is your duty to convey the same thing to your patient. Okay, this is coming from this. Everything is not due to cancer. Everything is not due to CSA that I faced in faced last 20 years back, right? So you have a responsibility to convey that to your patients, okay? But yes, there is a possibility that there is a term called trauma residual. I'll just touch upon today that trauma residual does remain, okay? And your duty is to find out that trauma residual and then deal with that.
Thank you,
Right?
ma'am. Thank you.
Yes.
They come to the clinic saying that they are living in a joint family and they have problems with the family dynamics with their in-laws and themselves. So, and it leads to a lot of trauma. A lot of patients suffer from dissociative symptoms, etc. So, I would want you to let me know, like, how, while living in that same environment where trauma is constant, how we can help those
Trauma in terms of verbal abuse
verbal
or
abuse.
emotional abuse?
Yeah, emotional abuse.
Okay, okay. And what is your question particularly?
So this is my question, that these ladies, they are living in that joint family setup and they are going through this trauma every day.
Mm-hmm.
At least one of the patient of mine was having so much of severe trauma that she started developing dissociative symptoms.
Okay, let us, all of us, we remember that dissociation is what? What is dissociation? What is dissociation? Yes, yes, yes. What is dissociation? Yes, yes. Absolutely, it's a kind of defense. It's a kind of coping mechanism, right? The question is why all of us, we do not cope in that way.
Like in this trauma,
That
same environment.
the approach should be entirely different, okay? Because it's a family situation, okay? It's a family situation, and primarily the communication pattern or the relationship pattern I was talking about just few minutes back, okay? And when you term it at emotional abuse, so you have to technically define to say that it qualifies to call it as emotional abuse. Right? Unless you define it and unless it meets the criteria of calling it as emotional abuse, it cannot. Okay? For example, if you say that I am being physically abused, okay, there might be some, how can we prove that? Yes, there is physical abuse. Yes? How? One is very obvious that you have some injuries mark, yeah, some signs and symptoms on the body. What else? Behavioral symptoms, and the most importantly, the confession of the person who is impinging that physical abuse. Okay, it is not that you are distrusting the person who is saying that. It is basically establishing, corroborating what she is saying. Okay, because the criteria need to be fulfilled. Yes.
Ma'am, so extending to what ma'am just said, a lot of young adults, adolescents continue living, they have to live in the same household where there is ongoing trauma, be it with a joint family or through parents or the dynamics in which they're living. And because of the age group, they're not able to escape or they have an alternative. How to approach such young adult clients or adolescent clients, or can we actually intervene in any way? Because parents.
Yes, you can. Yes, you can. And that is the Indian way of dealing with it. Okay. We don't have any sacrosanct saying that this is the line, we cannot cross it. This is TF CBT, trauma focus CBT, and we can't go beyond that. This is CBT, we can't go beyond that. India में ऐसे होता नहीं है.
The family will have to
Yes.
bring in the parents.
If you want to have 100% of outcome, okay, whatever your objectives are, if you include family, okay, for any problem or any illness, okay, your results will be kind of very much safe.
A lot of supervisors, a lot of practicing people say if a person's a young adult, they would rather not want to bring the family in because it's a transactional.
No, it all depends because you start with the confidentiality. So you have to take consent from that particular individual. And if many of the cases, if they are in trouble and the trouble is because of XYZ,
a lot
within
of
that network,
a lot of young adult clients say this is my place because they feel that this place was tainted now by trauma. They don't want someone because this is my sacrosanct space. But how do you then break?
So who is violating that? Somebody XYZ is violating that.
Yeah,
huh?
and therapy space is my space. I don't want it to be violated
fine.
again.
That's fine, but in therapy there are other spaces for other people also, na? But yes, he has to agree. If the solution are of two types. One, as a therapist, you can take your client and then make him happen that particular solution. Okay? And the other thing which are neither in your control nor in your patient's control. So what will you do for that? Right? You have to look beyond that if you want results or outcomes. Okay? But definitely, if you are putting it in a very different way to your clients will always be ready. Except barring 10% of the clients. But how you present it to him or her, how you convince him, that's the issue. He has certain secrets or she has certain secrets. Those secrets should not be out.
It's not about the convincing, which I was intending to say, but also the school of thought and trauma perspective itself. A lot of research around it says that yes, if the client is uncomfortable, that's a space from like a Winnicottian perspective as well.
That's fine.
So
look, there is a difference between adjustment issues and trauma issues.
No,
Trauma has to be established.
No, I'm talking about
fulfilling the criteria.
Trauma here.
Yeah, fulfilling the criteria. But the solution, that's what I'm saying, the solutions should be multi-folded. Okay? You should not look like कि यही fit होना है, नहीं हो सकता. Right? As I said, it is always when you deal with a psychiatric patient, you need a family member to corroborate the symptoms. This is the practice and this is encouraged. Right? And it is now compulsory as per the Mental Health Act that a family member should be involved in the treatment procedure. Why is that? Because the family has the responsibility. It is the it has the prime responsibility to support the patient in our Indian context. Right? And if you are giving the responsibility to somebody, accountability to somebody, you are not consulting him at all. That is the philosophy. Okay. Many situations in, as I said, 10% of the population, it may not happen also because they may not be ready, especially the adolescents and the youth, as you rightly said. But yes, how you present it, and if there is a need, other than that, it is not, you are stuck, he is stuck, you are not going beyond that, then definitely you have to look for something. Right? It's your clinical judgment. How to achieve your targets. Yeah.
As you mentioned something that it could be a adjustment issue or could be a trauma issue.
Yeah.
On that perspective. With due regard to every client that we see, to everybody's professional practice, I have seen a few observations in my clinical practice where, as you said, certain adjustment issues are also being termed or being labeled as a trauma.
I know.
So, is it something that the word trauma is loosening up its, gravity, or we are overusing it, or people? I mean, I see it quite kind of, young generation, particularly coming from adolescents or very young adults. They have this, the first thing they come and tell you that I have a very traumatic situation.
मैं तो trauma में थी.
I have always been in a traumatic situation.
Absolutely,
My family is a trauma.
Absolutely.
Like, do we have some kind of a criteria?
Yes, that's what I kept on saying, that it has to fulfill the criteria.
Yes. So I think that is something that we are going to discuss further.
Yeah.
Yes,
sure.
I just wanted to know about that.
Yes.
Thank you.
जैसे आप कोई भी बंदे को पूछोगे ना, सब बोलेंगे यार मैं तो डिप्रेस थी, ये हो गया और मैं बड़ा डिप्रेस्ड हूँ. बट दैट डिप्रेशन एंड क्लिनिकल डिप्रेशन इज वेरी डिफरेंट. Okay, they are referring to sadness. Okay, but depression is now every second individual knows what depression is. Absolutely. सब चीज डिप्रेशन में चला जाता है. Similarly, अभी younger generation, the more exposure they get from the internet, so it's like everything. There is a fight between two friends, it is traumatic. So that kind of fight between two friends, brother and sister, there is a huge fight between mother and the son or daughter. So that's quite traumatic. Okay, I'm not saying that कि ये नहीं हो सकता, but yes, to define it, we need to define it. That's it.
Right. So one more question which is related to a corporate setup. So we have so many corporate setups where there is the job is basically to get exposed to the content which other people cannot see. So it's a content moderation sort of a thing where they have to see that content so that other people feel safe to use YouTube and other social networking sites. And that is not done by AI, that is done manually by those people.
Okay.
So is this exposure to this kind of a content is trauma because that's their job that they are doing. And if that is trauma, they are not able to, of course, they cannot find the signs and symptoms and we have to identify that. But what we are seeing is there is an indirect impact, like we can see it on relationship issues or work-life balance and other things. So what is the relation between the two? And what is the psychological impact of exposure to such type of a content on human beings?
I'm not very sure whether I'm a right person to answer that, because I have not experienced such contents myself or similar experience through my patients. So I would like you to explain the type of content exactly. Is it pornography content? Is it pedophilic content? What type of contents they are exposed to, or it's a kind of threatening mail as a kind of cyberbullying? But you are saying that it's a part of their profession. So what type of organizations they are working for or working in, and then if that is their bread and butter, okay, if they write it or read it, that will give them livelihood. So that's a different perspective altogether. Okay. So it's again to define it trauma, then we need to have international discourse on that. right? But
Yes.
as of now, trauma definition doesn't contain this.
But
Right. Yeah.
yes, we need to consider that because these are big organization.
You please, I would be very happy if you bring particular case stories for Asian Trauma Conclave, which is happening 28th of February 2024 at AIIMS New Delhi. I'll circulate the brochures. I would like all of you to share your experience. What is trauma? What is not trauma? Right? Because all of you into practices, and many times we are stuck as clinician that whether to call it trauma or not, because you can't on the face of the client say that, no, that is not traumatic. Right? So you have to be very, very subtle, very clear, and very technical when you convey that message to your client. And at the same time, very soft, polite, and humble. Okay. So I'll be very happy if you bring forth this. Right? Right. So as many of you said, that trauma is a very subjective experience. It's a very, very personal experience. And many of our old generation kind of people, they think that कि बच्चे अपने आप भूल जाते हैं सब कुछ. आप अगर याद दिलाओगे तो ज्यादा खतरनाक वही है. याद दिलाना ही खतरनाक है. Right? And अच्छा ये कुछ गड़बड़ हो गया क्या मैंने? Okay, ठीक है. And but actually जब कोई सुनता है, एकदम अटेंशन के साथ सुनता है, एम्पैथी के साथ सुनता है, तभी से हीलिंग शुरू होता है. नहीं तो कहीं ना कहीं वो कोने में पड़ा ही रहता है. ठीक है? कहीं ना कहीं कोने में पड़ा रहने का मतलब है कुछ सिमिलर इंसिडेंट होता है या थोड़ा सा ज्यादा कम इंसिडेंट होता है तो वो प्रकट हो ही जाता है. ठीक है? एंड देन दोनों मिलके थोड़ा सा आपको ज्यादा तंग करने लगते हैं. राइट? बिकॉज इट इज स्टिल देयर. मेंटल स्कार्स दे डू नॉट गो. एंड ट्रॉमा में सबसे इंपॉर्टेंट जो स्ट्रेस के साथ जो डिफरेंस आप लोग बोल रहे थे, हाउ इट इज डिफरेंट फ्रॉम स्ट्रेस, जो ट्रॉमेटिक मेमोरी है, मेमोरी की जो फिजियोलॉजी है, ओके, एंड जो न्यूरोलॉजी, न्यूरोकेमिकल स्ट्रक्चर, इट्स एंटायरली डिफरेंट दैन स्ट्रेस. ट्रॉमा मेमोरी एकदम विजुअल याद रहता है, बिल्कुल याद रहता है, और वो फ्लैश करके आता है, ड्रीम में भी आता है, बार बार आता है. ठीक है? एंड ट्रॉमा मेमोरी, डीलिंग विद ट्रॉमा मेमोरी इज वन ऑफ द important techniques that all practitioners should practice, learn and practice. Right? Trauma memory is very, very important. Right? And that is how it is different when you say stress and trauma. स्ट्रेस में ऐसे पर्टिकुलर मेमोरी कुछ नहीं. आज किसी ने, बॉस ने मुझे झाड़ दिया, मेरे को डेफिनेट स्ट्रेस होना ही होना है. लेकिन कल अगर प्यार से बात कर दिया, ये गया, इसकी मेमोरी गया. ओके? बट ट्रॉमा में ऐसे होता नहीं. ट्रॉमा मेमोरी दे गेट इम्प्रिंटेड हियर. ओके? आप कब खोलोगे ये नहीं पता, बट वो रहता है, छोटे से कोने में छुपा रहता है. ठीक है? एंड many of us, we also think that discussing trauma will re-traumatize the people. When we were working back in tsunami and then Gujarat earthquake in 2001 and 2004 in tsunami, a lot of newspapers, they came up with the news that people from various government organizations, they go and then they tell the person to share their experience, and they just in the process they re-traumatize the person. Okay? I'm not saying that everything was wrong as news, but yes, when you open, as I told you, that trauma is a word which has come from the Greek word trauma, which means wound. So when there is a wound, okay, it has to be what? आपको क्लीन करना है. ठीक है? फिर हील करना है, तभी तो होगा. wound को खुला छोड़ोगे, the infection, what is the in fact risk of infection definitely ज्यादा है. जितना मैल धूल में जाओगे उतना इन्फेक्शन बढ़ा. ठीक है? it's same it applies to psychological trauma. If you are opening it, you have to wash it, heal it with medication, then close it. Otherwise the infection risk will always be there. ठीक है? Okay. And we used to say that government को हम सिर्फ एक ही लाइन बोलते हैं कि whatever you do, whatever disaster management you do, okay, if you are including psychological intervention, it is just a pinch of salt in your dish. Okay, without salt you can imagine what is the dish. Okay, can you imagine a dish without salt? That's it, right? So this is not going forward. ये आगे तो जा नहीं रहा है. Is it not? Don't you think that psychology is just a kind of pinch of salt? जिसमें भी mix कर दो वो tastier हो जाता है, सुंदर हो जाता है ना? थोड़ा मेथोडिकल हो जाता है, थोड़ा साइंटिफिक हो जाता है. ठीक है? And yes, since it is personal, subjective, as an experience, so the response also or reactions also become many times subjective or specific. But yes, there are common psychological reactions to traumatic life events, which start with disbelief and shock, and then coming with fear, anxiety about future, and emotional numbness, disorientation, apathy, feeling powerless, irritability, anger. If you look at all the disasters I just listed in the slide, in the previous slide, each one of these particular common reaction will fit into each of the incident that I listed over there. Okay? Irritability, anger, sadness, depression, difficulty in making decisions, difficulty in sleeping or biological functioning, and then some of the crucial physical symptoms. And key signs of trauma may vary across different domains. And if you look at the specifically for children and adolescents, there is a group of signs and symptoms at all level: thought and cognition, behavior, emotions and mood, and then social and educational, and then their perception, especially cognition, their daily life functioning, and the red signs. Okay. If an adolescent is very much stressed out or very much kind of into that traumatic experience, how does an adolescent react to it? आपको कैसे पता है जो लास्ट रेड सिग्नल क्या है? कैसे आपका ये रेड फ्लैग क्या है? कोई भी क्लाइंट आपके पास आता है और जैसे ही आता है आपको दिखता है कि ये कट मार्क क्या है यहाँ पे, राइट? दैट इज द रेड सिग्नल. Okay, that's the alarm. Okay, and it is very, very, very much common amongst the adolescents who encounter different traumatic life events, and that's the red flag. Right? Substance, yeah, I'm coming to that. And then substance. Okay, that's another. Okay, जैसे dissociation is a maladaptive coping, substance is also a maladaptive coping. Right? So these few signals, like somebody said dissociation, that's also a red flag. Right? ये तीनों जो चीज है ये बिल्कुल red flag है in adolescence stage of life. ये अगर कोई लेके आता है, you have to explore trauma. That's it. There is no if and but. It is your duty to explore if there is a history of any traumatic life event for that particular client. Right? Right. So one is self-harm, one is substance, and the third one is dissociation. Okay? Okay. We have already discussed it. Coming to more specific physical consequences, yes, death, injury, chronic unexplained pain or vague pain, you can say, that happens in stress also. In fact, eroded biological functioning, and then sexual dysfunction in reproductive age, especially in case of repeated child sexual abuse, penetrative child sexual abuse in the for any client. Okay, how many of you think that what could be the other health related outcomes of traumatic life incidents? Yes. Autoimmune. Okay. Autoimmune diseases. What else? Yes. बिल्कुल. और क्या? IBS. Yes. ये सारा स्ट्रेस के साथ लिंक्ड है. जब मेडिसिन से ठीक नहीं होते हैं तो रेफर कर देते हैं भाई साइकाट्री में चले जाओ. All psychosomatic symptoms. Okay. But there are certainly more than that. Okay. Let's see what evidence says. Okay. Just read it out. Okay. Many of the cardiovascular diseases, obesity, diabetes, they are directly linked to people who have encountered traumatic life events. Okay. There is a direct link, direct association between these two. And yes, heart failure, stroke, bronchitis, asthma, renal disease, polyarthritis, all these have been proved to link to traumatic life incidents. And irritable bowel syndrome, as you said, that is digestive diseases, COPD, and then other physical, a lot of physical issues or medical issues that are associated with history of traumatic childhood. And more importantly, infants born to women reporting multiple types of childhood trauma were at higher risk of bronchitis, developing bronchitis. This was very, very important, very, very recent. And there is a group of researchers who are following this, that suppose the woman has encountered or experienced a lot of traumatic life events before the childbirth, then how it is affecting the health of the child. And in fact, they are measuring the health outcomes for the infants, and they are more prone to develop bronchitis. Yes. Yes. No. Yes, if there is a molestation case and there is an attempt to rape, okay, and the process of treatment could be bothersome, could be failure of adjustment, and then higher than that could be traumatic. But again, we have to be careful when we define it. Yes. Sorry? Vertigo is aggravated by stress, definitely. But yes, the link directly between vertigo and traumatic life incident, I haven't, in fact, read it. It could be, I don't know, I'm not denying that, but I haven't read it. Okay? Yes.
Hi.
Yes.
Thank you. So I wanted to ask you about transgenerational trauma or generational trauma that has been known to epigenetically modify and been passed on because of the generation. As somebody mentioned poverty, instead of adverse life circumstances, wouldn't it be generational trauma and especially familial issues that have come
Yes,
up?
it is. It is. And the term itself says that it is transgenerational trauma,
Yeah.
where trauma is passed on to the next generation. For example, I'm saying, when in fact we are testing the child sexual abuse intervention module, there we came across a group of researchers from Canada and European countries. And that was a very beautiful session we attended in Canada conference, that how if the mother has sustained rape, how the vulnerability of the daughter increases for rape or sexual molestation. And there is in fact, increasing number of research papers in this particular area. And the vulnerability definitely increases. Like I said, that women giving birth to children, okay, normal women who do not have such life incident and women who have such life incident, definitely the risk of developing bronchitis is more with the children of the women who had such kind of incident. So there is transgenerational trauma, and it has evidence. It is gaining much more attention globally.
Just like a part, wouldn't information or trauma that has happened in like a cyclical way in a family, wouldn't that be also considered something that the children, especially adolescents, that it's passed on to them rather than something that they just, not just narratives, more like poverty related, because that's like a cyclical way that the family was dealing with things. Wouldn't that be something that is characterized as generational trauma rather than
Could be, but
adverse life event?
could be. I agree with you partially. We consider poverty as a kind of listed traumatic events or adverse life situation. I had the opportunity to deal with a lot of children who are into begging. Okay. My assumption was that yes, क्योंकि ये किताब में लिखा है तो होना तो यही चाहिए. They should reflect trauma symptoms.
Yeah.
Right? Why shouldn't they? Okay. But to my surprise and to my happiness, that was a happy bunch of child beggars. They are very happy wherever they are. There is no trauma symptoms at all. Okay. But हमारी लेंस वो ढूंढता है. Right? But not necessarily. They are happy because they are immune to that. They have grown up in that environment and that life situation. It's not traumatic for them.
Okay, but it was just like not just poverty, but a couple of other adverse life situations. They can
Absolutely, absolutely, absolutely,
Thank you.
absolutely. Only thing, that's what I'm saying. It is so subjective, so personal. Okay. So somewhere वो general Western concept आप देखोगे तो child beggars means तो traumatic होना ही चाहिए ना बेटा. But वो है ही नहीं तो क्या करे? जबरदस्ती trauma तो create कर ही नहीं सकते. They are quite happy. They are very happy. I mean, moving around the cars and doing things. Yes, I totally agree with you. But I'm saying that there are, I mean, sections, okay, where we need to kind of share our scientific literature with the world, right? So we can't take everything. That's why it is cultural. I told you in the beginning, it is multidimensional cultural context. Exactly. Because something which is accepted to me, it is not traumatic for me. Right? Yes.
Good afternoon, ma'am.
Yes.
Just there are two things that I wanted to say. One, as an extension of what she said, I would on this platform, because we all are professionals here, and it never has really bothered me. I've been a victim of child sexual abuse
Oh,
myself.
fantastic. Fantastic.
So,
I mean, I'm fantastic saying in the sense that you have the courage
I
to
know.
say that in front of
Absolutely.
us.
And I have made it a point to express this explicitly in other workshops when I'm dealing with children and
Very good.
teachers as well. And I don't like to call myself a victim. I call myself a survivor.
Absolutely.
To be very honest with you, whatever I have experienced, it's been with one of my cousins who's been who used to be my guardian angel sort of a person. Having said that, I'm standing here and I have educated myself, and there have been no scars that incident, has left on me, on my soul or my spirit. Now, my question here is that then, because right now I'm here and I do consider myself mentally sane, I want to ask you whether whatever I have experienced, does it still qualify as a trauma?
Okay, very good question. And to be very specific, please, can I ask you a few questions with your permission?
Yes,
okay.
please.
What age?
It was in school around 7th, 8th standard, the adolescence, puberty stage.
Was it penetrative, non-penetrative?
No, it was not like that. It was just more like, constant advances, physical advances. And cousins always share vacations together. So we used to always sleep together.
Yeah.
So it was particularly in the absence of my mother.
Okay.
So
technically speaking, yes, it
Yeah.
comes under that.
Yeah.
Okay.
Yes.
If you look at the definition and the criteria, yes. But again, when I move to criteria, the impact that left on you, that will qualify to call it a trauma or not.
Okay.
Technically, it is
Right.
because it meets the definition
Right.
criteria.
Right.
But to call it, for you to call it a traumatic incident or not, to some extent, it must be traumatic because it stays with you right now
Absolutely.
also.
Absolutely.
Right? So, scar doesn't mean that it is always ferocious. No.
Right.
Right? But it stays with you till you leave.
Absolutely.
Otherwise,
That's
it wouldn't have
Yes, I have not forgotten
right
about
now.
it. It's
Yeah,
still
yeah,
vivid,
it
like
stays
you
with you.
mentioned. It's
But
like a
yes,
vivid memory.
your resilience factors must be your protective factors, your supportive factors, your resilient factors must be surpassing your
Yeah.
experience
Right.
with encounter with non-penetrative
Right.
sexual abuse.
Got
Okay.
Yes.
So this definitely, जो powerful है वही ऊपर उठाएगा ना.
True.
ठीक है?
Absolutely.
And there is a
That's right.
concept called post-traumatic growth.
Okay. All right. All right.
Okay.
Got it. Yes. ma'am.
And for all the people who are over here, trauma, as I said you, that it is very personal, very subjective. It has tremendous impact, but yes, it doesn't affect all similarly. Okay.
Right.
And a majority of the population, if you consider that, almost 60 to 70% of the population, they overcome this. Okay.
Right.
Not all people, they suffer from
Right.
trauma impacts. Okay. Majority of the people, they overcome due to resilience factors.
Ma'am, there's one more question, and
Yes.
pardon my ignorance here, but I very recently I came across this term called emotional incest. I scientifically or even for knowledge, I have not explored it. I just read it, and I see the example in one of a very close family member, right? So this boy is 23 years old, and his mother has had, a very painful marriage, and she's divorced. Now, what I see is that many a times, most of the times, she treats him as her partner for all the practical purposes in terms of not physical abuse or sexual abuse, nothing like that. But she expects all kinds of compliance that she would expect from her partner, from her husband for that matter. So she needs to know where he is at all times. She doubts him if he's talking to a girl. She when she is not well, she ensures that she has all his attention, even if he is working. So I wanted to understand if this concept exists and if it can be in the purview of
It is, but can we take it off later?
Yeah, sure.
Because there is a reminder.
Sure.
Right? So I totally understand from the organizer's point of view, but I'm happy that it is really, happening in a dialogue way. I will leave both the presentations with the organizers, and I will request them to circulate. All of you take it, do it at your own level, do modification, but whenever you are presenting somewhere, just acknowledge this presentation. Okay, acknowledge the source, but you just spread it. Okay, so because I fear that I will not be able to complete the session due to this, but I don't mind that. Right? Okay. So quickly, so all kinds of psychiatric consequences, behavioral consequences, all of you know, and substance abuse disorders. As gentleman rightly pointed out, that approximately the risk increases 1.5 times for the adolescents for consuming illicit drugs after the traumatic events. And in fact, our national survey says that more than 50-60% of the illicit drug users, especially जो injectable drug जो लेते हैं, उनमें a very long standing history of traumatic childhood is there, right? So that is very, very important. But do you know that smoking is also linked to traumatic life events? Huh? It increases. स्ट्रेस में तो इंक्रीज करता ही करता है ना, बट देयर इज अ ब्रेन पाथवे, राइट, जो कि स्मोकिंग के साथ बहुत अच्छे से लिंक करता है और उसको बढ़ा देता है. ठीक है, आई डिडंट नो दैट टिल वेरी लेट, मे बी 6-7 years 10 years डाउन द लाइन. ठीक है, एंड दिस पाथवेज आर वेरी वेरी कॉम्प्लेक्स इन नेचर. दिस न्यूरोबायोलॉजिकल पाथवेज, हाउ आर HPA वर्क्स. ओके, so this has been proved through different smoking cessation programs. Okay, and then coming to symptoms will vary as per the age, sex, and the situation of the person. Yes, as all of you know that a child can experience thumb sucking, bedwetting, clinging to parents, sleep disturbances, lots of appetite, fear of dark, regression, etc. and etc.
Okay. Elementary school, yes, the symptoms will change a little bit, but the clinginess will persist. And school avoidance and poor concentration will add up to the above symptoms. And then during adolescence, delinquency could be one of the consequences of encountering traumatic life events. Yes, and especially school refusal after CSA, child sexual abuse, is very high. And some chronic medical conditions, traumatic medical conditions like cancer. Yeah. So some symptoms are shared by PTSD and depression. Okay. And the clinical presentation of CSA is little more kind of intense and little more pathological as compared to other life incidents happening in the childhood. And all of you might be knowing enuresis, bedwetting. Okay. Regression से सीधा 14 साल के adolescent bedwetting में आ जाता है. So that is enuresis, which is with medication generally doesn't go unless you do anxiety management and stress management with that particular children, that particular adolescent. And encopresis, anyone who knows it? Stool incontinence. Okay, that is seen in more younger children rather than in adolescents. And then vaginal itching and pain, anorexia, catatonic posturing. Okay, and it may confuse with catatonia as an illness, but this is a reaction to sexual abuse. Mutism. Okay, and mutism is very common. Okay, and I'm good at handling mutism. Okay. Not encopresis, but yes, mutism. Mutism मेरा जल्दी ठीक हो जाता है, ठीक है, बच्चों में, but ये वाला ठीक नहीं होता है, अभी भी I am struggling with that, right? And then amnesia, headache, pseudoseizures, all those dissociative motor disorders. Traumatic sexualization is very, very common. It's very common amongst pre-adolescents and adolescents. Okay, especially in terms of sexual preoccupations, repeated masturbation, sexually aggressive behavior towards others or towards people who are less powerful or children who are less powerful. And then when they grow up, they may develop aversion to expected sexual life, normal sexual life. They might develop negative attitudes toward their body. That is, that physical self-esteem might be very, very poor. And BDD, body dysmorphic disorder, किसी ने deal किया? BDD, that could be one of the outcomes of this or consequences of this. Difficulty in sexual arousal, आजकल DSM में sexual arousal का एक category of illness आ ही गया है, ठीक है? And confused sexual identity and problems in adult sex life, they are very common. And these are few of the pictures that we receive from adolescents, especially sense of sin, guilt, self-blame, and being bad. Okay, and sense of contamination. That is also very commonly seen amongst sexually abused adolescents and children. And this is regression. Can you imagine a girl who is 15-year-old in age can go up to this extent, that this is the extent of regression, right? And it is confused as specific learning disability. Yes. Mm-hmm. Mm-hmm. Can you, I will request you to repeat the question because maybe, I mean, there was no speaker, so others might not have heard.
Okay, suppose there's an adult, she's 35 years old. She's having disassociation wherein there is childlike regression happening. The age that she's regressing at, can that be used as a hint of trauma?
Yes, definitely. Yes, definitely. Yes, there's no doubt. Okay, so that's why it is very important to look at the developmental stage of life.
Okay. So then in that case, when you are doing therapy, or let's say you're trying to do TAT, is that something that you should be focusing more on, like at that age, asking questions related to that age so that you get a better understanding of what the family environment
You
is
have to
like?
definitely explore, and then once you are exploring, then do the assessments too. Okay?
Thank you.
So that's very important. Trauma and dissociation we have done. Borderline personality disorder is one of the commonest illness that is found amongst the adolescent trauma victims or trauma survivors. Yes, is gone. So the persistence of trauma symptoms, this is your answer. Persistence of trauma symptoms depend on many factors because it is multidimensional. It depends on the developmental age you faced it, your own gender, your status of that gender in that particular family, okay, and then the resource allocation in your family to you, and low educational level. For example, the children who are intellectually disabled, definitely the risk is more because they have no understanding what is happening with them. They can't describe that what happened to them, and they don't know how to express that also. So definitely the risk is more as compared to a person who has normal intelligence, right? So similarly, proximity to causative factors like incest, trauma happening within the family or in an incest relationship, so that is also there. And then the family support, the availability of medical legal support, and the cultural stereotypes, because stigma is associated with mental illness, stigma is associated with sexual abuse, okay, both when they combine, so the stigma is compounded, so that's a deadly combination, okay. So that is also very important to deal during the intervention. And okay, does that mean that जब trauma होगा हम लोग experience करके symptoms नहीं आएगा? Does that mean so? या सब लोग हम illness develop कर लेंगे? What is normal then? Trauma हुआ, then what is normal? How do we react? Yes, reaction तो होगा ना, response तो करेंगे ना, हाँ? सारा response PTSD तो नहीं है ना? अगर हार्ट बीट फास्ट हो रहा है, ठीक है, अगर पसीने आ रहे हैं, ठीक है, अगर डर लग रहा है, घबराहट हो रही है, तो डज दैट मीन दैट वी आर सफरिंग फ्रॉम PTSD? देन व्हाई नॉट? व्हाई नॉट? यस, yes, fantastic, fantastic. And all these things grouped together, we call it post-traumatic stress. हाँ, post-traumatic symptoms भी आप बोल सकते हो. PTS. PTSD होने के लिए काफी सारे चीजें चाहिए, क्राइटेरिया मीट करने के लिए. But PTS is normal, PTS is common, and PTS is absolutely present and experienced by almost all of the people who experience traumatic life events. Is that clear? Okay. So if you look at the difference between PTS and PTSD, so definitely PTS is common, normal, and often it is, as somebody said, it is a stress symptom or adaptive symptom in our body and mind, right? But PTSD, when you call it PTSD, it's a mental disorder which stays for months and years together with you, okay? But here if you say that if you are experiencing post-traumatic stress symptoms, more or less within a month you will be able to recover it at maximum, okay? Month se agar beyond chala gaya, so it can be qualifying for PTSD. Yes.
Initially, you're coping up with it by keeping yourself busy. You are engaging in your daily activities. Suddenly, you realize that the activities that you were keeping yourself busy in are no longer that important, and you process the loss. Is that also a form of PTSD that is happening? Or are you just denying the fact that, this person is no longer there? Is that denial or is that PTSD because you are getting nightmares?
That needs to be evaluated a little more in detail. because it's very difficult to kind of give views on this very brief information. It has to be kind of evaluated properly before we kind of say this is this.
Because like the nightmares are there, the flashbacks are there, how the incident unfolded, the person is having mental images. But at the same time, the person is engaging themselves in other activities, so they're not processing that. Or they're not allowing those things to come into their consciousness. So
That means they are trying to cope up with those kind of flashbacks. That's what you were saying.
No, that's what they're doing. I mean, is this a form of denial, or is this like...
No, it may be a part of their own struggling with coping with the flashbacks. That might be an adaptive process.
Okay.
But once they fail, definitely now they are functioning. When it affects the functionality, then only you will meet the criteria of pathological flashbacks.
Okay.
To call it pathological, it has to kind of affect your significant socio-occupational functioning.
And if that is not happening, then is
not happening. That means, as I said, the scar is there and the person is trying to kind of come terms with those impacts, but still kind of struggling. When he fails, then we can evaluate and then say that yes, this is happening. But you can prevent it. If the client is with you, you can evaluate and you can prevent. You can educate the person that this may happen and this is how you can deal with that.
In this situation, would it be helpful to encourage the patient to talk about the incident, or would that bring back flashback?
Yes, definitely after educating the person.
After educating.
Yes. So I'm leaving it here that all your questions, how long do these signs and symptoms persist so that you call it PTS or PTSD? Does PTS need treatment? What is the risk? How long do the signs and symptoms stay? What are the physiological signs and symptoms? What and why do they happen? So all those questions will be answered in these 2 slides. And coming to the neurobiology of trauma, there are a huge bunch of literature which establishes, in fact, the link between the structural and functional changes in the brain and different regions of the brain. And especially the early trauma can make the hippocampus smaller and increased amygdala functioning. Amygdala is famous for what? Any idea? Emotions, okay? And is the house for emotion, okay? And that is active till what point of time in our life? Very, very active. Any idea? Any idea? No? Till young adulthood. Okay? Right. Again, I am giving you a hint. Brain development कब बंद हो जाता है? हम 18 में adult बन जाते हैं. क्या brain develop बंद हो जाता है 18 तक? जब हम legally adult होते हैं? It doesn't. Right? 25 तक brain development at least 25 तक तो continues करता ही करता है. ठीक है? And कौन सा which part of the brain keeps on developing? Frontal. Okay? Frontal lobe keeps on continuing. And frontal lobe का काम क्या है? Executive functioning. What comes under executive functioning? Planning. Problem solving, decision making, simultaneous and successive processing of information, memory and working memory specifically. Okay? And iske bina kaam nahi chalta. Right? So that's why it is very, very important that prevention of early childhood traumatic incidents that shapes the culture and economy of a country and society. Right? The more we are able to prevent it, the more productive and financially stronger the country will be. Okay? And yes. So amygdala बहुत active रहता है. That is the reason why बच्चे रोते भी बहुत है, adolescent react भी हमेशा emotionally ही करते हैं. Because they can't help it. Because the processor is हमेशा is charged with emotions. So the output information processing तो यहीं पे होता है ना. जब active वाला जो process करता है emotion, वही emotion से charge भर पड़ा है, तो response क्या आएगा? Output वही आता है. So when you questions, parents आके बोलते हैं ना, why should he behave in this way? Why should he react in this way? Or she should react in this way? Why should he always be emotionally volatile? Okay, it's like something behavioral, but something, the culprit is here, right? Okay, and if you look at it, yes, definitely it hamara SCC, that is anterior cingulate cortex, that is also impacted through this, and our prefrontal cortex is very severely affected through early traumatic incidents. And that is why the child who is abused or being in a traumatic situation is always in the existential mode, that is the exertion mode of general adaptation syndrome, right? And बहुत अगर रहता है तो फिर वो exertion हो ही जाता है. The brain size also develops till mid 20s. The rational part of brain, as we discussed, that keeps on developing till mid 20s. And while the adult brain works from the amygdala, the the teen brain works from the amygdala. The adult brain after 25 works from the frontal cortex. Okay, and okay, so adolescence. Okay, what is the important apart from this physiological reason or neurobiological perspective of brain development? What are the other reasons why adolescent group is very, very critical for all of us? What is the other reason? Why are they more vulnerable to traumatic incidents, and what type of traumatic incidents they are vulnerable to? Yes, please. Absolutely, absolutely. Very, very good, very good. In fact, I was coming to that because it is basically dating experiences and violence within dating experiences, or emotional abuse within the dating relationship. Okay, and that is the age also for high risk behaviors like exploring sexual contents, and then exposure to substance abuse, exposure to in fact some petty delinquent activities, and then exposure to cyberbullying, especially nowadays, right? And then maybe if the school is located in a place where violence is quite common, or people in the community, they are mostly from each family, they are in each family, they stay, the person stays in jail. So those kind of situation, definitely the risk increases. Okay, now we have a project in Delhi for Delhi government schools, those who are located in high, moderate and low crime zones. Okay, the children belong to those areas, and almost self-reported PTSD is very, very, very high, along with depression and anxiety, but it's very high. So almost 500 schools we are dealing with, and people who are working with school children can get associated with us if they want to, right? So one is proper assessment, second is referral if there is a need for medication, and third is group, small group, school-based small group transdiagnostic therapy. This is absolutely developed indigenously in India. So if anyone wants to be a part of it, you can contact me, right? We have just started, so it's the right time to get associated with if anyone wants to. Okay, so there is a mechanism in brain that we say that you use it or you lose it. Okay, so because the adolescence is the time where a massive cell is produced, and if you don't use these skills, so then definitely you will lose it. Okay, and why shouldn't you use these skills? And this is because of the impingement of trauma and its impact. Okay, where if you are not using these cells, and if the adaptive and the functional use of these cells are not happening due to trauma and trauma impacts, so definitely you are going to lose it, and that may delay your development. May not be physical development, but in other areas of development. Okay, and myelin, any one of you might be knowing that that it is the basically the chemical that that works as a neural highway pathway between different parts of brain. Okay, and serotonin जो mood enhancer होता है उसी में ही produce होता है, and जो change करता है mood को adolescence age में, and myelin इतना ज़्यादा हो जाता है तो उसमें it is the main function of connecting different parts of brain and exchanging the information gets hampered. Okay, that doesn't function in a right way. So due to traumatic, because the person always try to cope up with these particular traumatic events. So I mean perpetually in the exertion phase, struggling and exertion phase. So then breakdown happens, and when breakdown happens, so all the networks in the brain, they get also affected. Okay, and we have already discussed the role of frontal cortex and prefrontal cortex, and primarily autonomic nervous system. Can you kind of see nervous system, overall nervous system, and then central nervous system, how it breaks through? And this we have already discussed. Okay, and especially you need to know that how the vagus nerve, they play the major role in reacting to traumatic life events. And how does it go? It starts from there. It just go like this vagus nerve. Okay, and vagus nerve का काम है हमारा, we have 3 types of vagus nerve. One is our ventral vagus, one is dorsal, and one is sympathetic. And you can see that the fight or flight hota hai, then our sympathetic nervous system is very, very active. Okay, and but it is expecting you to resolve the issue so that it goes down and settles down. But if it doesn't get resolved, so definitely the shutdown happens and the brain goes to the safe mode to shut down. And dissociation is a form of shutting down the brain or shutting down the brain from the traumatic memories or stressful memories. Okay, and then yes, how does vagus nerve का function क्या है, ये एक बार आप देख लीजिए. For the first and foremost is inclusion in the information processing of the brain and connecting to different parts of the brain. So it conveys information from the organ to the brain, and it controls the throat muscles and the air that goes down. So you might have experienced जब बहुत ज़्यादा stressful हो जाता है या फिर fearful situation होता है, आपकी गला dry throat हो जाता है, सांस नहीं ले पाते, breathing difficulties होता है, it's because of this only. Okay, and then it is also responsible for speech and muscle movements. It has a function to lower the blood pressure in case of illness or emotional stress. But if it doesn't function well or adequately or appropriately, definitely it can lower your blood pressure. So blood pressure will be always high, leading to stroke or some kind of COPD or some other illnesses. Digestive system also will get affected. That is why irritable bowel syndrome, right? And then dissociation, etc. Neuroendocrine system, and then what is HPA axis? Anyone who knows it? Yes? What is it? Bolo. What is HPA? Absolutely. Hypothalamus pituitary axis. Okay. Okay. So all of you read this. And what is SAM? SAM. What is SAM response? Huh? What is that? Any idea? क्या लिखा है? क्या लिखा है इसमें? This is sympathetic medullary function of the brain. Okay, this operates from sympathetic nervous system. Okay, the action taken by sympathetic nervous system, and when HPA and SAM they get associated, then lot of emotional arousal happen, and constantly if it remains constant for a longer period of time, it increases your hormonal level, that is cortisol level, and then the derailment of normal biochemical indicators, and eventually affecting the immunity of the person. Okay, and that's it. And this is how it goes from the central nervous system to different nervous system. That's it. That's it. So just relax and let me also relax. Okay. Okay. So now the question comes, as practitioners, should we explore trauma in each and every patient? Yes, by default, yes. That wasn't happening to my surprise when I joined AIMS also, but now it is into practice. All our residents by default in their history, they explore trauma. And we conducted a small dissertation, 2 dissertations, to find out the traumatic incidents amongst the patients who suffer from common mental disorders. So almost 50% of them they have. Right. And the other part of the study in a larger sample, that is still on in other, like in psychotic patients and personality disorders and other types of patients. Okay. So thank you. Sure. आप इसको चला सकते हैं, which is चल सकते हैं.
Thank you so much, ma'am, for your informative and interactive session. So participants, now be ready for the evaluation. So questions have been circulated in the group, in the Google form. So you have 5 minutes. Those are multiple choice questions. So just attempt it, and thereafter we will start with our second session.
Very, very easy questions. All the questions have been disclosed in the paper.
You are not added.
Add, okay. Add करो फटाफट.
Whosoever is not added, please raise your hands. Okay, only 3 of you. Please come to Ms. Prerna and she will add it to you. Please come one by one and get yourself added.
Can we look? मैं एक्चुअली अमेठी में हूँ. मैं देखती हूँ कब तक पहुँच पाऊंगी. ठीक है. कल सुबह दे देंगे. ठीक है ना. आज अगर मैं जल्दी आ जाती हूँ then it's okay. Today I'll do it. Otherwise tomorrow morning. अच्छा वो रकीस का इसका रकीस क्या नाम था उसका? BTS का. हाँ. So I got a call from
No, madam. Madam.
Settle down, please. We are about to begin with the second session. You can complete it in the due course, okay? See, the link will remain open till the end of the day. So in between, whenever you have better connectivity, please fill the forms. In between, we'll start with the second session. Thank you.
Is it over? Are we done? Are we done? Okay. Can I request all of you to settle down now? And you keep answering the questions during the session also if you want to. But there are only 5 questions, I think. Yeah. And very easy questions for you to answer. So I don't see why should you take more time to do that. Right? Okay. Yeah. So we'll proceed further. And the remaining part of PTSD and other things that you can see from the slides, because I'm leaving behind both the presentations for you. So yeah. So this has 2 sections. One is how to prepare for trauma intervention, and the second part is very brief about TFCBT. What is TFCBT and what does it look like, right? And okay. And the preparation starts with, you need to be reminded always that each person who comes to you for trauma treatment, he or she is a different person, right? So no generalization except some of the common symptoms. That's the cardinal rule, right? And you need to be reminded always all these factors which can work towards a manifestation of a group of symptoms in your client, right? So this is the base, and if you group all types of interventions that work for trauma or that are applied for trauma survivors, so you can group them broadly into 4 categories. One is low intensity, that is trauma counseling, psychological first aid, which generally happens in a disaster situation and in a crisis situation in a hospital setup also. But primarily the concept has emerged from the disaster trauma and community-based trauma management. And then little more than that in content and robustness is trauma counseling. And then after that, it is common therapies like psychotherapy or CBT, especially CBT, that is cognitive behavior therapy, which is very near to trauma specific therapies, that is trauma focus therapies. One group of interventions, I will not call it therapy, one group of interventions that is here, that is trauma informed interventions. Okay. So trauma focused interventions and trauma informed informations, they are very different set of information. Okay. But I need to understand what is your understanding about the difference between the two. Now, first question, who is the clientele of trauma informed interventions and trauma focused interventions? Who is the client? Yes?
For suffering are for trauma care, trauma focused.
Okay. Any other thought? Partially this is correct, but any other thought? Okay. No. No. In principle, it is not the answer. Okay. What else? I'll come to that. Okay. Why it is not the correct answer? Okay. Yes. What else? Any other alternative? Exactly. Trauma informed intervention is for a larger population. It is meant for the organization, for the institution, for the society, for the country, starting from the community till the school. When you say trauma focus, it is focused, starting from the individual. Okay. When trauma informed is for all. The environment is such, I think 2 of your dignitaries on the DAS, they also highlighted this, you might have forgotten, that it is at the institutional level. It's at a larger level. You have to make the society flourish after you make it safe, after you make it trauma free, right? And if you look at the Sexual Harassment at Workplace Act, that is a part of this philosophy. Okay, that legal framework is a part of this trauma-informed interventions. Okay, not officially declaring, but technically it is a part of trauma-informed care. But when you say trauma focus, it is focusing on one individual or a group of individuals with similar kind of trauma for trauma intervention. Right? So it's the context is different, the population is different, the objectives are different. Okay, and here you are treating a person with symptom. There you are not treating. You are making the environment safe, conducive, and trauma informed. Everybody knows what is trauma, and if it happens, what will happen to that person. Or if a sexual abuse or rape victim is working with my institute, then I must understand that yes, she is a victim, and this could be the impact on her. That is trauma informed. But you are trauma focused. You are treating a group of symptoms already manifested, and already the person has come up to you for treatment. Okay, here medication might be involved. There you don't need any medication. The approach is different. The method is different. Right? The scale is different. Everything is so different. Right? There is a large number of reported interventions for trauma. As I said, the objectives are different, the format is different, the process is different, the assessment methods are different, and the techniques used are also different. For example, CBT and EMDR. Okay? Maybe the objective is same, but the method is different. Right? So maybe the assessment is not same in both the technique, both the approaches. Okay? The process is also different, right? And when you are dealing with the trauma patient and going for the treatment for the trauma, you need to keep it in your mind that you are assessing a person who has a trauma experience, but you are not dealing with the patient, first of all. It's a whole person. And that concept has also come to psychiatry, that treating, not treating the symptoms, but treating the patient or the individual as a whole. Okay? And then, first of all, especially in many of the many of the disasters or life-threatening events, you need to first evaluate the safety concerns. Okay, if child sexual abuse is happening within the family, okay, and then how do you ensure the safety of that particular child or concern? There are cases where family members are involved or supported because of various survival needs. Okay. So how do you address those issues? So whenever you are evaluating, your assessment basically should concern with these points. And whatever assessment you are doing, you are absolutely doing it for the treatment, not on its own. Like you do disability assessment, SLD assessment. Okay, this assessment is for the objective is different, right? But here, whatever assessment you are doing, it is to be used in the intervention, because the intervention is kind of driven by the assessment, right? And it has to be comprehensive. It has to, in fact, be a continuous process. Okay, assessment at the baseline, in between after 4 to 6 sessions, and it has to be a continuous process regarding your objectives that you have highlighted in the beginning of the therapy, that what you need to achieve during these to attain 12, 14 sessions, right? And yes, here in this case, RAPO is always a good step, and it is an essential part of perhaps all therapeutic approaches, but here it is an essential approach. Okay, that is the bread and butter of trauma therapist. Okay, that's the kind of that's the thing. You need to have a very strong connection, very, very strong. Okay, not to be very over empathetic, but yes, it's a very strong tie should be there. It has to be a very good professional rapport. And then it goes like this: crisis intervention in many of the traumatic life events. You need to do crisis intervention first. And during the crisis intervention, you might take up kind of addressing the emerging and very impending issues, solving the problems at hand. That is very, very important when you do this. And then comes to history taking and clinical interview and formal assessment. Okay. And clinical observation is also a part of that. Quickly, we'll go to that. You know that why and how rapport building is important and how to do that. And there are 10 steps. You can go through these 10 steps. Most of you must be practicing this just to kind of refresh your memory. Okay. And crisis intervention, this Suraksha is specially for children who survived sexual abuse. And this Suraksha means what? Suraksha means as a clinician, we need to provide support, unconditional positive regard, which we already know, right? And reattributing the blame, which is not there in our this thing. Generally, when a person comes with, even in disasters, they come up with, ये मेरी ही फटी किस्मत थी, मेरे ही साथ यही हुआ. ठीक है, दूसरे के साथ उसके घर में तो कोई मरा ही नहीं, मेरे ही घर में 4 लोग मर गए. So it's my something due to me only. Okay, so reattributing the blame in most of the traumatic incident is required. So that's a part of our initial rapport. Okay, this is very different from the other interventions that you do, right? Isn't that true? You don't do reattributing blame in any first session that you sit with your client, right? But that's how it is different, right? And then accept as it is. That's a part of your curriculum. And then keeping courage, showing genuineness, and hope building. These all of you know. Only the unique thing is that crisis intervention in the first session and then reattributing the blame. Is that correct? Okay. History taking, it has to be very, very comprehensive history taking. It may take 1 or 2 sessions for history, completing the history and assessment. Okay. And history focusing on the initial account of trauma incident, mandatory reporting in child sexual abuse cases. Okay. And then taking consent for mandatory reporting, which is a difficult task for clinical psychologist or psychologist in a medical setup or even in a community setup also, because parents are unwilling to report the case. Okay, and you are in a fix because legally you are bound to report it. That is still a controversial area that is still being debated. Okay, and then the family history of trauma is an important history. And then do's of our effective interview. If it is a child, definitely we need to establish that the child is not hungry or thirsty. Okay, so generally जो बच्चों के साथ जो काम करते हैं, generally हम लोग बिस्किट या चॉकलेट वगैरह, चॉकलेट मीन्स थोड़ा सा मतलब ये टॉफीज नहीं, बट थोड़ी सी बार टाइप का चॉकलेट जो ये आता है, generally we keep. Okay, water and something to eat. Okay, and so that the child is first physically comfortable. Okay, before you begin your history and assessment. And for adolescent, generally we don't ensure that first in clinical practice, in my practice especially, others might be doing. But yes, when the session is over, so while extending my gratitude, I do offer them to have a bar, right? Not biscuits, but bar, yes. So my adolescents are very happy with me because whenever they do good things, I do give them a reward, and that is only chocolate or a ball pen. That's it. 2 things are constant. So they know that when they do the homework, so they will get it, right? So yes. As I said, towards the end, you have to appreciate the adolescent for coming to you and talking about you. And if it is possible, so please do immediately reinforce the adolescents. Okay, and they will stay with you, right? And yes, many clinicians, they ask the questions because when a trauma victim comes to you, you a lot of emotional ventilation happens even in the first session. Lot of crying happens, lot of aggressive spells happen, and lot of in fact restlessness happen. So many times you feel that to kind of touch him or her and to kind of pacify the patient. But if it is possible, please do not do that. Or if you really want to do it, take permission from the adolescent and then do that. Touch him or her. So these are the cardinal principles what you should follow, right? And then don't hurry up or push the adolescent to give you the trauma history. Okay, he or she may not be able to express that in their first visit. So hold on your questions and patience. And many of us, we are habitual saying that how I know how difficult this must be for you, right? We are very happy. It is here only. Please do not do that in trauma victims. कल को अगर कोई उल्टा करके बोल देगा कि आपके साथ तो रेप नहीं हुआ, आपको कैसे पता मैं कैसे जा रही हूँ, आप तो फंस गए ना. And which is true. कितने भी आप पढ़ लो, कितने भी प्रैक्टिस कर लो, you can't really experience, right? So be careful when you use these sentences or phrases. Okay, everything will be okay. You will never have to talk about this again. This is the first and last time this is happening with you. So you'll be able to kind of prevent it further. No. As a cardinal thing, safety is the first issue. As I told you in Suraksha, safety concerns are the first and foremost concern. Okay. You are not sure whether this is going to happen again with your client or not. But yes, educating him on safety education, that is your duty. And making him aware that yes, how he can prevent such incidents. That is your duty, right? Yes. What are the leading questions and what are the most kind of non-leading questions? There is a hierarchy that many in a hurry to get the trauma information. We asked that did the perpetrator share a secret with you? What is that secret? And then again, where did he touch you or where did she touch you? Okay. And did the perpetrator touch your private part always or it's occasionally? So in a hurry, these are all maximally leading questions, which ought to be absolutely avoided, right? You have to open up with from a general pool to a specific pool of questions, from a non-leading framework to a leading framework, because by the time you come to the leading framework, second or third session, the adolescent is comfortable with you and you are also comfortable with the adolescent. Okay, so that both of you are ready to explore about the trauma in more detail, right? Detail आप पढ़ लेना. Observations, yes, this is very important. As I said, in Indian context, we do see that in clinical practice, unless and until the adolescent is very much no to intervention with the family members, we would generally like to involve the family members with the treatment so that many of the issues that is happening within the family that is taken care of, right? And when you are calling both of them to your session, then clinical observation is very, very important. You need to observe that what is the type of communications they are having, what is the body language they are exchanging between them, okay? And what is the way that the adolescent is kind of manifesting the non-verbal body language in front of the family member. So you will come to know many of the untold stories when both of them or many of them sit together. Okay, the entire family dynamics, communication pattern, and the relationship dynamics within 1 or 2 sessions you will come to know. You don't have to assess, you don't have to ask. Right? So clinical observation is very, very important before you start any trauma therapy. Psychological testing you all are trained on. So there is a whole list of scales for very different traumatic incidents. So you can take this list and find out. So there is a huge list of things. Clinical assessment, yes, we do ensure that multiple informants are there, because an adolescent might say that I am sexually abused, non-penetratively abused or penetratively abused, but the body language, the trauma symptoms do not reflect or corroborate what she says. Her verbal and her non-verbal things are not matching, right? So we need informant or the secondary source. But yes, we have to be careful when we do this and with the consent of the adolescent, always. Okay. It has to be holistic and accurate, and it should help in your treatment planning. As I said, the observation of congruence between the verbal and non-verbal body language. When there is incongruence, definitely you need a person who can corroborate what is being told to you, right? You can select a screening tool, whatever type of illness or symptoms you want to assess, and especially if an adolescent comes to you with a severe trauma history, then definitely you need to rule out PTSD symptoms and other mental illnesses, and you have to segregate both and how these illnesses or symptoms are impairing the person's daily functioning, and is there a self-harm risk. Okay, these points, I mean, what are the externalizing and internalizing symptoms that the client is showing to you, and whether the client is re-experiencing or having flashbacks or having intrusive thoughts, or he is into active avoidance. So in your first 2 sessions, these questions should be kind of focused upon, right? Is there any somatic manifestation or associated somatic symptoms, right? And then you can close the assessment. All your essential skills that you need for counseling, they are very much needed here also, right? So there is no separate set of skills that you need. If you are practicing these kind of 6 skills, that is good enough to deal with trauma patients. Only you need to know the assessments and what needs to be assessed and what techniques to be done. And again, trauma focused therapy, as we have seen it, thus comes under the, if within the evidence-based research category, trauma focused intervention kinds of that is at the top level of evidence for trauma in adolescents and children. And you decide or select the intervention depending on many indicators, especially the personal characteristics of the adolescent, the trauma characteristics in the adolescent, the treatment needs of that particular adolescent, and the therapeutic setting you are in. Okay, that is also very important. If you cannot provide privacy, if you cannot provide multiple helps to the person, there might be a medical help, there might be some issues, somatic symptoms which are associated with the person. So you need to have the setup to provide the treatment. So it's always good to be in a kind of team to work with. Yes, principle of trauma intervention, as I kept on saying, it has to be safety first, right? And then feeling of connectedness and belongingness with the therapist, that is the rapport, okay? And then self-efficacy, instilling hope, that you all know that. And there are many child-focused intervention, and trauma is one of the major evidence-based research, that is trauma-focused research. And the number of sessions generally is 24 in Western literature, and frequency is once or twice in a week. Duration is 60 to 120 minutes. Generally, you won't see 120 minutes for any other illnesses, right? But because it is extended, because there is in vivo exposure and gradual exposure, so there are many techniques that you do which takes time to bring results. So you need थोड़ा सा एक्सटेंडेड सेशन आपको चाहिए जिसमें आप थोड़ा उसको स्टेबलाइज करके बैठा के देन यू प्रोसीड फर्दर. Then session progress happens in this way: history, and during history it is the rapport building and ventilation of feelings and cognition about the incident. Then relaxation, that includes grounding, breathing, games, activities, storytelling, everything, chit chatting, and then trauma narration, then affect modulation, etc. and etc. And monitoring the progress is very important here. Every 4 to 6 sessions we generally say that you work with your client and ask him deliberately to prioritize what he wants from you. Okay, and then as per the client's priority, then you fix the number of sessions and then evaluate the person's experience, your experience, and the treatment outcomes. Right? Your experience, person's experience, or your client's experience, and the outcome, that the target or objectives that you had set with your patient. Okay, this is not moving. Nahi ja raha. Okay. So when we say trauma focused CBT, it is not a radical departure from the CBT per se. Rather, it offers very specific techniques, very specific strategies, and specific ground rules to accomplish the treatment goals. Many of you might be using CBT. So it is a kind of extending your CBT to focus on very specific techniques and very specific strategies to help your client to heal the symptoms related to trauma. Okay. Many of us, when we do, especially when a court case comes to us, many of the lawyers, they think that this particular therapy is a fact-finding method to establish whether sexual rape has happened or it has not happened. Okay, who is the perpetrator, who is not the perpetrator. Okay, and whether mandatory reporting has happened or it has not happened. So, but it is not a fact-finding method. Okay, it's not an investigatory session. No, not at all. And especially the share karte hue experience. Do not share your personal experiences with the adolescent. Okay, at least in the first 10-12 sessions. Never. Okay, you might kind of say overarching statement that many of us, we have similar experiences. Okay, not intending to say that I have similar experiences. Do not use I. Okay, keep it open. Yes.
If at all, during the entire process, we establish that whatever the the patient has come to us with a particular thing, say for example sexual abuse, but we establish through all of these processes that it is not the case and the entire thing is not there is no truth in it. Now that we have this information, what do we do with it? How do we handle it?
Okay, so there is a method called confrontation, but there are different types of confrontation. Okay, in our communication skills, there are different types. Confrontation is a method. Okay, but there are different types of communication, different types of confrontation. Okay, there is a direct confrontation, which is challenging, which is threatening, and you may lose your client if you employ that. That is an indirect confronting. Okay, so there is a story building method within the indirect thing. Okay, then you present a story within your session, you present a story, and that works wonderfully. Okay, that works really good. Okay, so then you ask a solution from your patient. So what to do? Okay, and then you see how he reacts. All your problems will be solved.
Sure. Thank you, ma'am.
Right? Yeah. Yes, the principle of trauma intervention is always person-centered or incident focused. when you are dealing with patients, especially in a hospital setup, it is never incident focused, okay, or event focused. It is on the, I mean, it's the focus on the symptoms or the problems, okay. Here it is focused on the event or the incident. So I'm just telling you the difference how trauma intervention is different from what you would normally do, okay. And it is very much process oriented and dynamic in nature. As I said earlier also, it's a continuous process and it is dynamic in nature depending on the emerging issues that the person or the patient comes up with for every session, okay. And it needs professional competency to deal with children with many traumatic incidents, especially child sexual abuse cases, penetrative type of sexual abuse cases. But you are still very, very young, and gradually over a period of years, you will be able to master it. So if you are not able to deal with a case, okay, you are not feeling competent to deal with a case, please do refer. Don't feel ashamed. We all fail and we all should fail also. Right? Because even if you are taught with A to lekar Y tak taught kiye ho, there will be a Z that you don't know. Right? So be comfortable with your failure, your incompetencies, and be open to refer the case somebody else who you think might do a little better. Okay? Or refer to somebody, some established center which can deal with the issue. Okay? And your self-care is very, very important, that because trauma especially, we don't talk about self-care in any other therapy, but in trauma intervention, your emotions, they kind of sway along with the emotions of the child or adolescent sitting in front of you. If he cries, he or she cries, you feel like crying. Okay, if he describes the abuse within the family by the father, you are also becoming aggressive and kind of rebellious, which is very genuine, right? So it's very, very important. You are the child or adolescent is gone, you are taking back, carrying it to your family when you go back in the evening, right? So self-care is very much essential. Leave the trauma when you go to your home in the evening. Yes, please. Yes. That was there in the previous slides,
Yeah,
so
I
you
must
can
have
visit
missed it.
that.
Okay.
Yeah.
Thank
you. TF CBT will go directly to that. Okay. This is the acronym of TF CBT, which talks of, okay. First is psychoeducation, which is common to all therapies, in fact, therapeutic approaches. But here it is important that in case we are dealing with a child, a caregiver is involved in the psychoeducation process. Okay, this is mandatory in TFCBT. Okay, and yes, we do not focus on parenting skills in any other therapies, do we? Do we? In CBT, do we focus on parenting skills? No. In EMDR, do we? Huh? No. In REBT, do we? No. In psychotherapy, do we? No. Here we do, especially in case of children and adolescents. TFCBT is meant for children and adolescents. The evidence of TFCBT is established on children and adolescents, right? So the approach is different, the method is different, the techniques are different, the format is also different, and the objectives are also different. So parenting skills are emphasized, and relaxation and stress management skills we might be practicing in many other forms of therapies, but here we focus on grounding. How a relaxation is different from grounding? Have you heard the term grounding? What is grounding? Focusing on the present and the surrounding around you in that particular situations. Okay. Let me go back to your school days when you used to study and doing the homework and feeling sleepy and drowsy. Your mother or father or family member saying that go and wash your face and come back. Right? Pani ki chinta laga, come back. What is that? That's a type of grounding. In a low intensity, it is grounding. Okay. And somebody is like patting you. So gaya kya? Right? So gaya kya? Tu pad raha tha. Kya pad raha tha? Okay. So that's also a form of very simple way in and around. हम लोग grounding ये करते हैं without naming it technical. This is a grounding technique, right? And then larger relaxation, any form of relaxation method you can use, JPMR, any form of simple breathing or any other form that you are convenient of. Then affective expression and modulation, this is also not there in any therapy per se. Okay, because as I said, this is meant for children and adolescents, and amygdala is active, so a lot of emotional reactions, a lot of emotional symptoms come up with, and you really need to work with the children and adolescents to express their negative emotions and modulate their negative emotions to act in their favor. And there are very certain very specific, in fact, certain and specific mediums. How do you do this? Okay, how do you work with the emotions of children and adolescents? How do you modulate their emotions? How do you regulate their emotions with the help of different mediums? For children, तो आपको जितने भी खिलौने कि ये है mediums वो आप कर सकते हो. Self portrait बहुत सारे use कर सकते हो. Cognitive coping and processing, this is very trauma focused. And there is a session on trauma narration when you are establishing how the entire memory chain of memory that is associated with that particular incident. Okay, and reattribute again that how it has happened. Then you ask the person to visualize the people who were there, the situation, what was there in the situation, what color of dress the other person was wearing. There are certain questions that you ask as a leading, as a set of leading questions, so that it is helpful for the person to recollect and reorganize the incident with you, how it happened. And in the process, you will come to know that whether it is a kind of factual information or it's a fabricated information. Somebody has asked that question. So trauma narration जब आप establish करते हो, जब session करते हो, आपको खुद ही पता चल जाता है कि ये सही में है, ये सही है या गलत है, सही information है, गलत information है. ठीक है, fabricated है तो आपको वहीं से पता चल जाएगा कि ये fabricated नहीं है. ठीक है, and since everything is done on the piece of paper in black and white, so it's like in front of him only. So it's like you will come to know. You know, in vivo mastery and exposure therapy, all of us we are taught with, and here it is visual imagery technique जो use करते हैं, with grounding करते हैं, and we ask every time to kind of journal the entire narration in different styles, so that every time he connects it, when you join the dots, it gives you the same picture. Okay, and the more you exposed to the adolescent or the child to the same memory within your under your safe hand, so definitely the reaction to trauma, the emotions to trauma, the arousal to that traumatic memory, that start receding. Okay, so that is the technique, but you have to close it every time you finish the session. Okay, you have to close it properly, and then you send him or her back. And conjoint parent-child sessions or adolescent children parent sessions are very important to deal with the cognitive restructuring and cognitive distortions, right? So that CBT में आप करते हो, उसको reattribute करोगे trauma session में. ठीक है? This is the structure of the session that you do. If there are 12 sessions, ideally they suggest that trauma stabilization phase you build in 1 to 4 sessions, and then you do the psychoeducation, relaxation, grounding, affect modulation, and coping. Getting the cognitive distortion and cognitive coping during the first 4 sessions, and then fifth to eighth sessions, you expose the person to the traumatic memory, and with the help of trauma narration and conjunct sessions, and then the last 3-4 sessions, you must focus on rebuilding or reintegrating your client to his to take him or her back to his normal functioning. But generally what I practice is a little different, because I take more time for the stabilization phase. It takes on an average around 6 sessions for me to kind of complete the stabilization process, and then 2 to 4 sessions for trauma narrating and processing, and integration and consolidation I take a little more, a little less time as suggested. Okay. And there are many smaller techniques. You can go through the presentation. Parent psychoeducation, what to educate them on and why. That is also very in detail is mentioned. You can proceed to that. Different types of grounding is also there. You can see those grounding techniques, and whatever affect modulation strategies with the help of some aids, you can do that. Different mediums, how do they help the person to ventilate the emotion or to re-establish the memory related to the traumatic events, that is also there. You can see those things. You might not have seen the set of such aids, therapeutic aids, but for trauma victims, we always keep a set of established therapeutic aids to allow them to express or ventilate out their emotions easily, right? And this is especially, this is a very Indian intervention, Indian technique to work with adolescents, especially in community setup, in small groups, and adolescents who are victims of penetrative or non-penetrative sexual abuse, right? This you won't find it anywhere else in the world or any other therapy. Okay. And trauma narration, it's a chain of event and specific emotions and feelings associated with it. Use of drawing in explaining, these are not in any other therapy. That is how TFCBT is different, right? And then debriefing after every narration. Okay. Reenacting trauma while trauma narration. This is also a very unique technique in TFCBT that we do. And the more you do, the more skillful you will be. Okay. This is a very, you can say very, very technical technique, you can say. Technically, it is very technical. Okay. Once you learn it and do it under supervision, then you build your confidence. Initially, आपको लगेगा कि मैं गलत कर रही हूँ, सही कर रही हूँ, but under supervision अगर करते हो, तो gradually आपके confidence build हो जाता है and technique आपका, I mean, हाथ में आ जाता है. Memory is very important, as I was telling you in the first session, that we focus on our trauma therapist, we focus on recognition memory, recall memory, and reconstructed memory. Okay, it's very important to reconstruct the entire experience of traumatic life events with your client to kind of build the story. Okay, so for that, visual memory, auditory memory, because जो flashbacks आते हैं वो visual memory है, जो intrusive thoughts आते हैं वो auditory memory है, auditory thought, I mean thoughts है, cognitive thoughts है. So ये सारा बहुत काम करता है. And yes, details you can see. Managing trigger events. There is a case study. You can read that how a small thing can also act as a trauma reminder, right? And potential barriers. Yes, that's done. We are almost done. Yeah, how to end the session. Okay. How do you generally end the session and end the therapy? Anybody who follows this, I'm sure none of you. Then how do you end the session? Yes, please. Okay. Okay.
I use hypnosis.
You use hypnosis and suggestions also?
Yes.
Okay. But how do you end it? My question is, how do you end your sessions
So
or the therapy?
or the therapy, if means like the client has certain issues
Hmm.
which she is dealing with.
Hmm.
Now, through different techniques of hypnosis
Hmm.
or NLP,
Hmm.
we put them out of the like now the thing visualization and all thing. Now the problem you have means like altered or reframed it. Now see yourself into the future. What all these incidents that are triggering the client? Like suppose if a client has a molestation case or
No, I am trained in hypnosis, so I know. Right?
No, I'm telling for means
But what I'm saying is that have you kind of done this yourself on any adolescent or child?
yes, I have treated
Okay.
a client.
Is it reported?
Reported
Because hypnotherapy or NLP is not, both of them, they are not established therapies for trauma.
Yeah.
Okay, they may come up in future, but if you have cases, please do report.
I'm pursuing PhD and my topic is role of hypnosis in treatment of depression, anxiety and stress. And my
No, I am specifically talking
No,
about
yeah, that I
it
understand.
is established in depression, anxiety. But I'm specifically mentioning, if you have case report on any individual with trauma history and you are addressing trauma symptoms through that, do please report the case. It is not there in the literature. That's why I'm saying.
Okay.
Right. Right.
Thank you.
Yes, this is a better way to end the session and to give this paper to your patient or client. Right? What is this? It takes only 5 to 7 minutes before you end. Right? You can take a printout and you can do practice with every patient, irrespective of age, sex, gender, religion, everything. You must do it with all clients, and it gives you a fantastic response. Yeah. Right? So we end here. You know the conclusion. The tree of sustenance gives you the kind of reply saying that, the last note, take home message that you survived the abuse, so you are going to survive the recovery too. Right? So, thank you very much. So, any question, any doubt, we can take it up because we are already late. I am already, taken half an hour of the sessions for us. So that we can discuss once the group is being made. Okay. And all of us, we can meet in February 2024 as a part of Asian Trauma Conclave, 28th February. I will circulate everything and your organizer will kind of circulate everything with you. Right? So all of you get into your research, get into your clinical practice, do establish your cases or research and do participate, present your paper and participate in the Asian Trauma Conclave. Right? Thank you very much. And it was a very wonderful interactive session. So thank you all. So thank you very much. Right? So thank you, Rashmi ma'am. Thank you, Rushi ma'am and the entire team. Thank you so much, ma'am.
Thank you, ma'am, for focusing on such a pertinent topic. I'm sure our participants must have been immensely benefited from this insightful session. Now I would request Dr. Rushi to share a token of appreciation. Ma'am, please.
So much. The entire team, very nice for your hard work session, ma'am.
Thank you, ma'am, for being with us. So now we may break for lunch. Oh. lunch milega. Yeah, but we are going to rush.
And there are many good sessions. I must say there are many good sessions which will reinforce whatever I have shared with you in the morning session. Okay, but do make it interactive with your resources. Right?
So, and the questions once again have been circulated for the second session. So please fill it in the due course and move ahead for the lunch. There are 4 names that I'm going to announce. So please come and meet me. Payal Gupta, Priyanka, Shefali Chopra, Ayushi. Are you people there? Please raise your hands and please come and meet me. Okay, for 2 minutes, and rest can proceed for the lunch. We are running short of time, so 15 to 20 minutes at the max. Thank you. We'll have our next session on interviewing skills with trauma-informed approach. Our next esteemed speaker is Dr. Shalini Anand. I hope ma'am has joined the session. Am I audible, ma'am? Phone number नहीं है हमारे पास.
Yes, ma'am, you are audible.
Okay. नंबर है? डॉक्टर ऋषि को बुलवा लें? अश्मिता, जरा डॉक्टर ऋषि को. Please settle down at the back. Dr. Shalini, hope you have joined. Am I audible to you?
Yes, yes.
Wonderful. Ma'am, kindly open your camera. Yeah. Good afternoon, ma'am.
Good afternoon.
And I welcome you on behalf of IBHAS, Amity University. All of you, please settle down. I would take this opportunity to introduce Dr. Shalini Anant, our next guest speaker. She'll be joining us online. Dr. Shalini Anant has completed her graduation and post-graduation from Delhi University. She has completed her MPhil and PhD in clinical psychology from NIMHANS, Bangalore. She has been practicing psychotherapy since 1993. She worked as faculty at Delhi University, Tata Institute of Social Sciences, Christ University, and Montfort College at various levels from UG to PhD. For the past 8 to 9 years, ma'am has been learning and practicing trauma therapy. She has independently conducted 6 batches of training program in trauma therapy, besides several shorter workshops on the same. She feels passionate about empowering fellow mental health professionals in the trauma-informed approach and use trauma-informed lens in working with various physical and mental health concerns. We welcome you, ma'am. Thank you.
Thank you. I have asked permission to record. Can please someone give me permission to record?
Yes, ma'am. It is being done.
Ma'am, it's going to record already. The link will be shared later.
Okay, fine. Good afternoon, everyone. So, am I visible and audible? Okay, I suppose I am visible and audible. I believe all of you have just finished your lunch. Hope you enjoyed your lunch. So, this is a very challenging session, not just because of the topic, but also because of the timings, because after lunch, our digestive system requires us to take a little rest. So it will be a challenge to keep you awake and engaged in this session. I will try my best. So as you might be aware, it really helps to first take care of ourselves, which is true in all situations. It is especially true when we are talking about or learning about trauma therapy, or when we are carrying out trauma therapy also. So what I would like you to do is to remember to prioritize self-care first. I want you to remember to keep breathing. Sometimes when we are very tensed, we hold our breath, we don't even realize it. So especially remember to exhale. Stay well hydrated, have water whenever you want. Stay nourished, I don't have to say after your lunch break. And stretch if you need. Stretching sometimes just helps us come to the present. Some examples that I might give in between might be a little triggering. I try to give not very disturbing examples because it's a very short lecture. It's not even a workshop. But even if in the short lecture, if something is disturbing, please remember to take a break if you need it. There are a few techniques that we use with clients, which we can use with ourselves. So, noticing our contact points. So, noticing where your feet are. So, just becoming aware of your feet. Just lightly press them in the ground. Notice your backrest. Notice your seat. And if possible, try to look around and connect with one thing that you can feel safe with and calmed with. It can be the touch of a soft armrest. It can be your bag. It can be a friend who's sitting around who helps you feel calmer. It can be anything. It can be a particular color. Okay? I can see that people are still coming in. I would really request everyone to settle down. So during the session, I invite you to keep participating in the questions I have put in. So this will not be a passive listening lecture. You will participate continuously in the presentation. I request you to avoid sharing any personal information at all about yourself. This is not a therapy session, and it is not very healthy to share our personal information of very private nature publicly. And also similarly, avoid discussing any case in detail here because it's a very short duration and we won't have the privilege to discuss any case in detail. So some of the things you might already be aware of, but before going ahead, I will like to give you a little introduction. What is trauma? So trauma, as we know, I won't read out the slide, but as we know, it is anything which has hurt us. It's a wound. And what hurts whom can be very different. We cannot decide what should hurt and what should not hurt someone. Someone can feel hurt with something very obvious like a severe physical abuse or sexual abuse or a disaster or a community violence kind of an experience. But sometimes it's also very hurtful to go through underwhelming experiences. All of us are familiar with overwhelming experiences, but some underwhelming experiences can also be very hurtful. Like having felt unseen in childhood, having felt unheard in childhood, having felt like I don't matter, especially in childhood. So, traumatic experiences can be one single traumatic incident, like meeting with a road accident or a bomb blast or a shooting experience or any kind of such one-time experiences. But they can also be experiences which are repeated over many years. So I would like you to give me a couple of examples that you can think of things which can go on for years and years. Organizers, would I be able to hear when participants speak? I am not able to hear any responses, please. I am not sure what's happening. Okay, I'll go ahead. So we are using the phrase trauma informed. Okay. Now, trauma has become actually, while we are defining trauma here, trauma has become a slightly overused, misused, even abused term. All of us are psychologists and we know how we feel when anyone and everyone on Instagram claims to be a psychologist or a counselor or a therapist. A similar thing is happening about trauma also. Almost everyone is claiming to be a specialist in trauma, which if it is a reality, it would be a very good thing. But usually there may be only a very theoretical understanding of trauma in people sometimes when they are using, these terms like I am a trauma expert or a trauma informed therapist. So, but what does trauma informed stand for? So trauma informed is a broader term. Ideally, any and every setting needs to be trauma informed, like a school, like a hospital, like any organization, like the army, like a state, like everything should ideally be trauma informed. So what does trauma informed mean? Trauma informed stands for a program, organization, or system that realizes the widespread impact of trauma. So first thing is to realize that trauma is not something that happens very rarely. That trauma is very, very widespread, very highly widespread. Whatever numbers we can think will always be an underestimation of trauma. Trauma is very highly widespread. And the system understands the potential path for recovery also. So when we understand that it is very widespread, it is not to feel defeated and hopeless and helpless that, oh, there is trauma everywhere. But a system which is trauma informed also understands there are different ways for recovery, and also there are different ways to prevent, as we will see further. So the system recognizes the signs and symptoms of trauma in clients, families, staff, and others who are involved in the system. The system responds by fully integrating this knowledge about trauma into their policies, procedures, and practices. It just doesn't remain at a theoretical level. They are able to implement into different policies and everything that they do. And one thing which is very important that a trauma-informed system would do is to resist re-traumatization. Okay? So if a system is doing all of these, then we would say that this system is a trauma-informed system. And what does trauma-focused therapy refer to? Trauma-focused therapy is a specific approach to psychotherapy. It is one of the approaches of psychotherapy that recognizes and emphasizes the understanding how traumatic experiences impact a person's well-being at different levels: mental well-being, behavioral well-being, emotional well-being, physical and spiritual well-being. So it is a little more able to focus on the individual aspects. Also therapy, it's a therapy, so it also aims to offer different things, offer skills and strategies to empower the person, to assist the client in understanding and coping with different emotions and memories that are tied to the traumatic experiences that they would have had. And this trauma-focused therapy has the end goal of enabling the client to create a healthier and more adaptive meaning of the experience. So there's also, you can see a little element of logotherapy. It is not done only through logical analysis, but eventually clients are able to make better meaning, better sense of what they went through in their life. So we look at the trauma model or the trauma therapy model or trauma-informed or trauma-focused model as a trans-diagnostic model, and symptoms that we are all aware of, like anxiety symptoms, depression symptoms, all these symptoms, how are they looked at in this model? So clients are not seen as a collection of symptoms. We don't look at the person. This is not a very new thing. That is the basic humanistic approach also. They are not seen as a collection of symptoms, but rather as people who are attempting to recover. And emotional pain is necessarily intrinsically negative, but it is required to recover. Trauma-related symptoms are seen as attempts at metabolizing or internally resolving distressing thoughts, feelings, and memories. So when the person is having these symptoms, it is not considered as a very sad thing. It is the brain's way. So brain, as we know, is a very, very adaptive organ that we have in our body. It does what we need at that time. So the brain is trying to bring up those memories again and again, the flashbacks, the thoughts, the feelings, the memories, because the brain is trying to metabolize those at its own level. Thus, trauma-related symptoms are seen as recovery focused. They are attempts by the brain, maybe not a very successful attempt, but they are still attempts at recovering the memory. Now, you might be knowing, if you have learned a little bit also about trauma, that the trauma is not inherent in the event. Can I please hear from the organizers? Is it possible for me to get responses from the participants? Can you please tell me yes or no? I am not sure if anyone can hear me. Dr. Rushi?
Ma'am, can you hear us?
Now I can hear someone.
All right, wonderful. Sorry, there was a bit of a technical glitch there.
No problem.
Now you can ask questions to the participants and the participants will be able to answer this.
Okay, great. So, as we know, trauma is not the event. Trauma is not exactly what happened. Trauma is what happened to the person as a result of that event. Now, I want to ask you, what do you understand by this? Anyone, please?
Ma'am's question is, what is trauma according to you all? Anybody who would like to answer this?
My question is not that, sorry.
Ma'am.
My question is, when we say trauma is not the event, trauma is what happened to the person as a result of what happened. What does that mean?
Ma'am, it means the impact it had, whatever the incident or the event was, the kind of impact it had on the person, how it affected his emotional behavior, how it affected his social adaptations, how it affected his future perspective and day-to-day life. So that is what it means.
Absolutely. So even deeper than that, the level at which these experiences can affect is at the belief level. So we are all familiar with CBT, right? So CBT says core beliefs develop as a result of what? Yeah?
Ma'am, the subjective appraisal or experience, how am I appraising the situation?
That is what happens after we have grown up. What is the root cause of this way of appraising things, according to CBT? According to CBT, someone has a belief, I am lovable or I am unlovable.
Early childhood experiences.
Exactly, early childhood experiences. So in early childhood, whatever events are happening, or in cases of neglect, the necessary events that should have been happening when they have not happened, will they affect the person's belief? Yes?
Yes,
Yes or no? Okay. Give me some examples of that. Suppose a child is crying himself to sleep every night. Okay, and nobody at home knows. We can't say for sure, but what is likely to be the belief that this child may develop about oneself?
Child is sleeping, yeah. Not sleeping and crying every night. In the night.
The child may think that I am not lovable and people will not come to me if I am in need.
Absolutely. I'm unlovable, nobody will come to me, I'm helpless, and I don't matter. Okay? Now, if once in a lifetime it happens, this kind of experience happens, it may or may not affect a child, but if it is a pattern, then it is very highly likely to affect the child. Okay? Now, by giving this example, why I gave you this example is most of the times, even amongst psychologists or therapists or mental health professionals, the word trauma is used only in cases of sexual abuse or severe physical abuse or any calamity, natural calamity, or some things like that. Neglect is very often neglected even by mental health professionals as something that can be very traumatic to a person. Okay? So basically the content of what happened, what specific thing happened does matter, but does not matter so much. What does matter is how what happened or did not happen has affected the person. So let's see, what do you think about this? Which of these is likely to affect us more? The recent traumatic experiences that happened, or those which have happened in early childhood, and what is your reason for thinking so?
Early childhood.
Why? Why do they affect us more? Why wouldn't a recent experience affect us more?
Because in early childhood, we need support from others. We are not able to take care of ourselves that well. I mean, children are dependent on their own system.
Mm-hmm. Okay, so children are very vulnerable, children need others, and if I can get into neurobiology, the neurobiology of a child is still developing, just as the body is still developing. They have small hands, small legs, small body. Similarly, the brain is small. And not just small, the brain also has lots of interconnections between the networks which are yet to develop, which are still developing. Okay? Now, if I give you an example of a plant, a small plant, and suppose you tie the small plant downwards, okay, and you let it remain like this. Within 15 days to max 1 month, even if you open what you had tied, the plant may remain like that. Yes? Now, if it's a fully grown tree, if you do that, obviously, first of all, it would be very difficult to do that. But even if you are able to do that, it may or may not have that much of an effect. Right? So similarly, when the child's neurobiology is still developing, the effects are much more of various experiences which are happening in early childhood. Then, just as I was saying, trauma is a very overused and misused and abused word. Many times we avoid using the term trauma. No, this is not trauma. So both the things are happening. Sometimes we are minimizing something as saying, no, this is not trauma. It was not so disturbing. Sometimes we are calling everything trauma. So trauma is a relatively new field. So people are still trying to figure out what to place within the bracket of trauma and what not to place. So what I want to say is that I believe that absolutely there is probably no one who has not had any trauma. All of us, including me, including you, everyone has had trauma. The severity differs, the age at which it happened differs, who did whatever experiences to us will differ. And of course, if it was a trusted figure, then it has a much bigger effect. We all know that very well, right? Another thing we know, or we might be knowing, is that something happened is not the only factor, but especially, if we are looking at attachment theory and if we are looking at all trauma as attachment trauma, then whether the parent made any effort to repair after whatever error they made, or they made no effort to repair, is also very instrumental in whether something is trauma. All I want to say is that we don't have to be so scared to say that something was trauma, because sometimes we avoid saying it thinking that if we call it trauma, then that means that it is the end of the world. That is not how it is. Trauma does not necessarily lead to a complete breakdown in adulthood. It may simply lead to a decreased ability to feel satisfaction or emotional or physical pleasure, or it may lead to a repeated pattern in all our relationships. It may lead to having boundaries which are too rigid, or boundaries which are too loose, like, we share anything and everything with everyone. That is also possible. So it can affect in different ways. It doesn't have to only show in the form of a complete breakdown or a severe mental illness. Okay? And the hopeful thing, the good thing is that there are effective ways to heal traumatic experiences, and we don't have to just passively accept it as one's fate or avoid calling it trauma because then we think that there is no way out. So when we are doing a trauma-informed interview, there are a few basics to keep in mind. The focus in trauma therapy is not to just discuss things, not analyze things, not making sense of the symptoms. Now, all of us are trained in similar institutes like where I have been trained. So most of the times the questions that are asked are, why do you think so? What makes you feel so? And does this feel like that? And so we are asking lots of questions. Tomorrow I will talk to you more about the limits of talk therapy, how limited talk therapy is, and how there are so many other things that we can do. But in any case, the purpose of trauma therapy is not to keep discussing or analyzing something. The therapist's self, the therapist personhood plays a very integral role in therapy. So my own beliefs and feelings about different things. My client is undergoing domestic violence, what my beliefs are about that. My client has chronic backache, what my beliefs are about that. My client is a man, my beliefs about men. My client is a woman, my beliefs about. So my beliefs about anything and everything are going to significantly affect the process of therapy, whether or not I say those things to the client. Now let's look at some of the questions that we can ask. So we are all trained to take case history, and usually there is a column for trauma history, and usually we respond to it in terms of 2 alphabets. We write NA most of the times. Am I right? So the reason is that we have not learned how to take trauma history. The reason is that we are not aware of what trauma is, so we don't know how to take trauma history. So we just write NA. But trauma history is as important to take as any other subheadings in our case history format. So we take developmental history, family history, medical history of all clients. Similarly, we need to take trauma history of all clients, but we don't have to rush into it. So it's okay if you don't take trauma history in the very first session. In fact, we advise against taking trauma history in the very first session until and unless the client has themselves reported something on their own. Now, I have more questions and I want everyone to be able to answer, please. Now, just tell me, I'll give you a few examples. Tell me, out of these people, in whom are you not at all likely to find any trauma? So there's a senior professor of philosophy who's a very responsible husband and father and son. Only he has occasional anger outbursts. Are you likely to find trauma in this person in their life or not?
Yes.
Second, a young adult woman who has MPhil and PhD in clinical psychology. She has a very sweet smile. She's very highly compliant, very nice to talk to. Are we likely to find trauma in her life or not?
Yes.
A client who's very sacrificing in all her relationships and wonders why people treat her very often like a doormat. Is there likely to be trauma in her life?
Yes.
Someone reports that they have had a perfect childhood and their parents did the best that they could to make them what they are today. Are we likely to find trauma?
Yes.
The client says now they are too old to delve into what happened in childhood. They just want to reduce their anxiety in the here and now and be better at work. Could there be trauma in their life or not?
Yes.
There's a very senior psychologist trained in trauma therapy and trained in several approaches to trauma therapy. Could there be trauma in their lives or not?
Yes.
How come? People who are trained in psychology, who are very senior professors, how can they have trauma?
They've lived their half life without this, and even if they are trained, they can have. I am. Yeah. So even in their lives, they can have. In their early childhood, they can have experiences which are traumatic, or maybe they can incur trauma like accidents or domestic violence, etc. Even if they are trained.
Okay. And besides accidents and domestic violence, could there be any other trauma that they might have been through?
Vicarious trauma.
Okay, vicarious trauma. Or? Could there be codependency in any of them?
Beside that, there could be emotional abuse, neglect, other kind of traumas also, which are not like very obvious.
Okay, there can be complex trauma. There can
I
be.
believe trauma affects irrespective of where you stand in life, or what is your economic status, or what your social status, or what your professional status is. It affects us in multiple ways, in subtle ways.
Okay. Very good. Okay, so a few words of caution when we are taking the trauma informed interview.
Monal Vishwas, you have joined on the link. Please switch off your mic, please.
Okay, so again, most of the times in our training, we are trained that you first do the assessment, you take the entire history, and then you go and present your history, and then a diagnosis is given, and then it is decided whether they would receive medication or therapy or both. Am I right? Now, if we are a trauma-informed mental health professional, we will not take trauma history right in the beginning, because it can trigger an increase in distress, it can increase flashbacks and all the other symptoms. So instead of rushing into assessment as quickly as possible, what we need to do is provide self-regulation tools and other resources to the client. So in a way, you first enhance people's resources, you teach people stabilization skills, you teach some other skills, you do a lot of resourcing. Only after that, you will delve into taking trauma history. Okay, the international model, which suggests the different phases of therapy, says that there are 3 phases of therapy. The first phase of therapy is called stabilization, skill building, resource building. The second phase is called trauma processing, in which you will first take the trauma assessment and then you do trauma processing. The third phase is called integration, termination, and follow-up. So you don't take the detailed history right in the beginning. Somebody comes, okay, so tell me, have you been sexually abused? Tell me, have you been physically abused? You will not do that. That is very unethical. In fact, even in the first session, if a client is talking about something, especially if they're giving you details of the trauma experience, you need to interrupt. You need to interrupt. We have been taught that we should not interrupt. You need to interrupt. Of course, you need to do it very softly, very gently, very politely, but you need to interrupt. And you need to do some calming and stabilizing exercises before you go into the details of what happened. So we have been taught that empathy is the most important thing in trauma therapy. Stabilization is much more important than even empathy. It is much more important than even ventilation or anything else. Okay. So this is a different thing. Don't assume that it's just a few terms that we can learn and then we have to keep doing the same thing that we have been doing. That will not be a trauma informed approach at all. Very often while giving trauma history, the client may give you only an official story or a cover story, minimizing significantly the real experience. Can you think of some examples of this? Give me some examples. Sometimes clients may just tell you only a very surface level kind of information or just gloss over everything. Can you give me examples of that? Sometimes clients say, yes, everything is fine. No, my family has been very healthy. My childhood was very happy. All these are examples of that. Can you think of any other examples? Okay, so when the client says any such things, take it with a pinch of salt, take it sometimes with a cup of salt. It doesn't have to be true just like that. Stay respectful of, if the client does this, stay respectful of this verbally and non-verbally. You don't have to challenge them. You don't have to confront people. Stay sensitive, stay empathetic, and stay prepared that mostly under conducive circumstances, many nuanced details will later get added by the client if they feel safe enough to share with you. If they feel that you will neither get shocked nor you will directly or indirectly tell them, no, we are not supposed to think like this, think positive, be positive. If the client is not worried that you will say any of that, usually they would be able to give you more details. So when we are doing trauma assessment, it's not like everything else is separate and there is one section on trauma history and we take that. Ideally, you do the entire assessment in a trauma informed way. So you ask about the current support system. Okay, you ask whom they are staying with. Are they eating regularly? You will be surprised how many clients are not eating a regular healthy meal. Do they sleep on time, get up on time? These are some very basic questions. Your Maslow's first rung of hierarchy. Ask those questions. Also, anything that the client says, I'm all the time anxious, I have all the time this lower backache, I have a migraine all the time. Hear them out very calmly and patiently after when it seems appropriate and doesn't seem like you're challenging them. Ask them, do you remember the last time when you did not have a backache? You remember the last time you were feeling slightly relaxed or you did not have a migraine? So ask for the exceptions to symptoms. Okay. Ask strength-based questions. What all do they like about themselves? This is a question which many clients really fumble upon because there is so much of internalized toxic shame. I am defective, I am faulty, especially if people have been in psychiatric treatment for a long time, they have only negative beliefs about themselves or mostly negative beliefs about themselves. Ask them what all they like about themselves. And I become a little insistent with this question if they say nothing. So I say, okay, what if I were to ask your loved ones, your friends, anyone who likes you, if I were to ask them, what all do they like about you? What do you think they might say? Then you start getting some answers. With one client recently, when I asked, the same thing happened. Nothing. I'm just an honest person. In the next, because I stayed with that question, I held space for this question. He comes back in the next session. I have to tell you something. I said, tell me. You were asking me something the last time about what all I like about myself. I like this also about myself. I said, good. So for clients to believe that it matters to you what they believe that they like about themselves is also a beginning of therapy. Don't focus only on problems. Current resources. Now, current resources are very important to work with. When we are doing trauma therapy, it doesn't mean we keep talking trauma, trauma, trauma. We do a lot of resourcing work. It can be called resource informed therapy in a way also. You ask how they are sleeping, how's the quality of sleep, dreams, nightmares, the usual things which you are anyway used to asking. Also ask them what helps them to sleep better. So they might have figured out some of the sleep hygiene techniques already. So you can, whatever is working well for them, whatever is their method for stabilization. You know, whenever you're feeling anxious, what is it that helps you feel slightly calmer? Or when I go and sit with my grandmother, it helps me feel calmer. When I listen to bhajan, it makes me feel, so whatever is their system, you don't have to get into it. You don't have to, even religion, you know, I never get into religion, but if someone is bringing that up, I use that as a resource. If the person has that resource, you utilize that. So whatever their resources are, you can build further on the resources. Ask how they feel about coming here to seek help or being sent, especially if they have been sent to take help. Ask how they feel. The reason is, again, similar why we were asking strength-based questions, because maybe nobody has even asked them how they feel to be in psychiatric or psychological treatment for a long time. So do make space for that question also. A few things to note when we are doing trauma assessment. The most important tool for assessment is not your questions, but it's always observation. Observation is the most important tool for your assessment, especially when it comes to trauma assessment. So you observe anything and everything. You start observing from the time you get the first call or from the first time the client is walking into your room. Notice their posture, how they are walking, how they sit. I had a client who was that senior professor of philosophy, which I have given in the first instance that I asked you. He was so slouched and he was dragging his feet, and he's a very, very senior professor. And many sessions later, when I did bring that up, that, you know, what is the reason that you slouch so much? Is there any backache? Is there any concern? So he laughed. He said, once for fun, I went for a theater practice. And he said, the play director told me that, oh, you stand like a question mark. So, and the amount of trauma that's there in his life is very difficult to even imagine. So notice people's posture while walking in, while sitting, while they're talking about a specific topic. If you notice their shoulders go a little higher, if you notice their jaw becoming tighter, if you notice the frown on the forehead, if you notice anything, if you notice restless hands, feet, anything while they're talking about something, or while they're talking about one person, or while they're talking about one phase of life, that gives you an important piece of information. You may or may not bring that up then and there. That will depend upon how stabilized the client is. If the client is not stabilized, you will first stabilize the client. After the client is stabilized, you may choose to ask very gently about it. I noticed some muscle tension when you were talking about this. You notice that, and then we get into therapy. So I'm not teaching you today about therapy, but then we get into therapy. Notice people's breath. If you start learning to notice people's breath, that itself gives you so much information. We are not trained to observe people's breath. People hold their breath up and they are breathing very short and shallow when they are anxious. Okay? So notice people's breath. Notice people's speech. They are talking. This, we are slightly trained in, you know, how much they talk, how fast they tone and volume and everything. Pauses. Notice facial expressions. Notice restless hands and feet, as I said. Eye contact. Eyes widening at anything. Lighting up of eyes is a very important thing to notice. When you are asking about resources, what helps you calm down? Anything that makes the person's eyes light up, make a note of that. Use that as a resource whenever you can. Okay? When their eyes become sad, of course, that is easier for you to understand what that means. Anything that is making the client tearful, they are attempting not to cry, especially male clients do that. They'll try to hold on their tears and the voice may become choked. So you notice all of that. When you notice any efforts at evading some topics or minimizing things and so on. Or when they are saying something, but things don't match. So, information was reliable and adequate and all that. You're trained to do that. But much more helpful than that is to ask for examples. Oh, my family was a very loving family. Okay. Can you give me examples of that? Can you tell me what all you remember? And what else? And what else? And what else? If it was actually a very loving family, if they actually had a very happy childhood, they will of course have a lot of examples. If they say it was a very happy childhood, but I don't remember, then what does it mean? If they don't remember, then how can they remember it was a happy childhood? So it may be more of a politically correct, socially appropriate thing to say. Also note any events or experiences the client mentions repeatedly. Now, even if you're not taking trauma history, if a client has told you something once and then at another time they are mentioning this, whether they say that this was traumatic or not, you make a note of that. That is a traumatic experience for them. Or of course, it can be a happy experience also, which they are repeating. Again, make a note of that and use that as a resource. Or anything that makes them teary-eyed or choked, even when you're not taking trauma history. Now, how do we look for trauma? We can look for any affect. We know what is affect. So any affect that the person reports, or you can observe happiness, sadness, fear, anger, hopelessness, anything that you notice. Behavior or behavioral urges. Now this includes all the addictions. As you know, all the addictions, when we think of addiction, first thing we think of is alcohol. Second, we think of substance. But addictions are many more than this. Gaming addiction, Netflix addiction, binge eating, sugar addiction, relationship addiction, relationship to abusive people addiction. So anything, it can be anything that the person has been doing repeatedly, or they say, I feel so much urge to do this and I have to really control myself. That gives you an indication. You can ask, there are many questions we can ask. When was the first time you felt like this? So currently I have a client who smokes, a woman client who smokes. She's 55 to 60. She smokes about 3 to 4 cigarettes a day. But, and I never said you have to quit or don't quit, nothing I said. She says, I don't want to smoke anymore because it becomes a project. I have to hide and smoke. When anyone is about to come, then I have to smoke before they come, then hide all signs of that. Nobody has told. Nobody can tell her anything. She's not a child and her husband has no problem with that. So then we traced back. I said, okay, so, when you're saying that you have this urge to smoke, but you don't want to smoke, but when you're saying you don't want to smoke, still you've been smoking for many years, there must be something that. So she says, yeah, it gives me a sense of soothing. It almost, one day she was in a very reflective mood. She said, it gives me a sense that I and only I have to soothe myself. And a cigarette makes me feel calmer for some time. I said, okay, can you just stay with that? The feeling that I and only I can soothe myself and a cigarette can help me soothe. And imagine you can float back on your lifeline and tell me what comes to you. Because we are also in therapy for a good 4.5 to 5 years. So she can do this quickly. So she says, I can see myself as a 5-year-old. She's 58 or 60, maybe touching. I can see myself as a 5-year-old, and I have two younger sisters, and my second sister developed polio. So the second sister is very young, and this woman was 5 years old. And everyone is looking only at the younger sister. Every day, all the guests come and everyone is looking only at her. And I have been waiting and waiting to be looked at. And I slip out of there on a sly and go to another room and I'm sucking my thumb. And she says it feels exactly like this. So we processed that. And she has actually cut down on her smoking. She's not addicted per se. It's more of a psychological addiction, as we call it. So, any behavioral urge can help you trace back to trauma. Cognitions, we spoke briefly about cognitions already. I'm not good enough. I'm not in control. I'm vulnerable. I'm unlovable. Any of these cognitions, either verbalized by the client or any behaviors or any patterns reflecting these cognitions, give you an idea that there's trauma. Somatic. This is again one area in which we are not at all trained. When I started learning trauma therapy, this used to be like some other language that I had to learn. But any somatic symptoms, any chronic pains, any chronic physical symptoms, I have clients who had asthma, migraine, lots of people with IBS, lots of people with different digestive issues, different breathing, and skin. Skin is one thing. Dermatology is, I think, probably all trauma therapy. So lots of somatic symptoms show up because of trauma, and there's this very famous book which all of you must be knowing or you should know about. It's called The Body Keeps the Score. The body keeps the score of trauma, and even if we think nothing has happened to me or nothing has affected me enough, look at your body. If there are any symptoms which are chronic meaning they have overstayed the time that they should have ideally stayed, given whatever reason there was, there is most likely trauma. So Gabor Mate, who is a very famous trauma therapist internationally, earlier the belief used to be even, Engels, that biopsychosocial theory, it used to say that everything has a biological, psychological and social cause. Gabor Mate goes to not only him, but he, amongst many people, goes to the extent of saying that there is no chronic physical illness in the world without trauma. There is no addiction without trauma. So trauma is so widespread, and any of these can give you an idea about trauma. Okay, so let's see a few helpful questions. We need to always take history of positive childhood experiences. So you might have heard of ACEs, adverse childhood experiences, which there are 10 plus 1, so 11 total ACEs, which all of you must be knowing or you should know. But we also need to take positive childhood experiences history with everyone. So you can, in your mind, if you want, you can keep answering these questions for yourself and see what all comes to you. Who did you feel the safest with as a child? Okay, and then you'll ask the client, can you tell me more about that? Who believed in you? So many times, clients especially with sexual abuse, I have a client who was sexually abused by her driver over and over again. And whenever she told her mother, the mother would say, no, he's my favorite driver. He's so nice. You are only trying to get him out because you don't like him. So she was so small, and she didn't have any reason to lie, but her mother didn't believe, but her father believed, thankfully. So ask the question, who believed in you? Who believed in your truth, in your version of the story? And then ask for any detail that they have about that. Who helped you feel truly seen? Who helped you feel heard? Who was not just doing things for you as a list of check boxes or as a sense of duty, but they were doing it, making you feel seen and heard and important and like the center, right? Who did you feel safe to talk to? What are your memories about that? Who kept your emotions in the center without reacting excessively or breaking down, making you become worried about them? This is very common amongst people who have a parent with preoccupied or ambivalent attachment style. I don't know how familiar you are with attachment styles, but people who become extremely worried or anxious at small things usually have a preoccupied attachment. And very often clients say that, my mother was so anxious that whenever I went to the mother would become so flustered that I had to keep my emotions to myself and I didn't have any space for my emotions. I would start taking care of my mother's emotions rather than her taking care of me. Who did you have the most fun with as a child? What all comes to your mind when you think of that? Who heard you without interrupting? Again, many times people are busy interrupting or quick to give suggestions about what you should do. So who was listening to you without interrupting you? Who guided you or empowered you? This is again another very common thing. People say that I was always expected to top the class, but nobody guided me about how to study and I didn't know how to study even though I was very intelligent. So ask questions like who guided you or empowered you, whether it is in studies or it is in cycling or anything that they were fond of doing. What are some of your memories which would bring a spontaneous smile on your face or which make you happy or proud? Tell me, I want to ask you now, why do you think we have to ask these questions? How does it even help to ask these questions? Yeah? It's so?
Help in the process of stabilizing also because there are certain positive experiences that can help them calm down and as well as to sort of neutralize during the initial assessment set that it's not all negative and have instill some sort of a hope because sorry because somewhere when you're taking the history for trauma incidences, people can become extremely I would say closed up because they're talking so much about their negative experiences. So the positive somewhere also makes them feel more connected to some of the positive experiences of their childhood.
That is very true. So we see two kinds of responses. There are people who say, no, everything was nice, everything was wonderful, and they believe that they should, as soon as the should comes, there's a problem. They should not look at what all went wrong. Then there are people also, clients, who have told me, I don't want to think about the positives because I'm kind of denying all the problems that I went through. So, what's important is that, like TA, many of you must be familiar with TA, that, it says that until and unless there were some positive strokes or negative, at least some strokes have been there, otherwise we can't even survive and the spine shrivels up and we die and things like that. So something has been there because of which we are still alive. Which does not mean, and I say this very emphatically, it does not mean that we have to go on telling people, look at the positive, look at what all went right, look at what all was good for you. Why do you have to focus on that? That is very, very anti-therapeutic to do. But it's important to also have this foundation. This kind of information will give you a little bit of a foundation over which you can do trauma processing. Okay, it gives like a little anchor to the client to be able to do the trauma processing. These are similar questions. How much or how often during your childhood did you feel able to talk to your family about feelings? Feel your family stood by you during difficult times? Did they enjoy participating in community traditions? And did you feel a sense of belongingness in school? Did you feel supported by friends? Did you have at least two non-parent adults who took genuine interest in you? This is especially relevant in the context of India because we still have indirectly a joint family system. Even if people are not living together, there are enough contacts with extended family. Did you feel safe and protected by an adult in your home? So if there are a few of these which are there, these and these which are there, it becomes, so these are your resilience factors in a way, which make us feel hopeful that all the difficult traumatic experiences can be processed and there is some foundation and some cushion which is there over which we can work. So we can ask more questions to take attachment history. All these positive experiences are also part of attachment history. Do you remember any time you were physically hurt or unwell or sad? Every child would have been either physically hurt or unwell or sad sometime or the other. And then what did you do? Or then what happened? Suppose they say I had to take care of myself. Or suppose they say that, oh, my mother started crying and my mother fainted and this and that. These will give you very important information. In the first one where they always took care of themselves, it's more likely, there's no fixed answer I can give you in this. It's not some tips like that, but more likely that the person will develop avoidant attachment. In the second example where the mother broke down or cried or whatever, more likely the person would develop ambivalent attachment. As a child, when you got upset, whom did you go to? Can you give me an example? And then what happened? And then what happened? So you develop, like I was saying, ask for examples. Do you remember ever crying? Then who consoled you? Do you remember ever crying alone? Or did you ever try to hide your tears? What all do you remember about this? Was there anyone around whom you would often feel confused? This is about many times either a parent or a grandparent is very manipulative or tells lies in front of the child, and the child becomes very confused, and they say that I used to feel very confused about, I know this is the truth, but my parent is saying that all the time. So especially when there's a parent or a grandparent in the family with personality disorder, like a cluster B kind of a thing, it is likely to happen. So you can ask this question as if they were probably not being very honest. Can you tell me how it might have affected you in your life? Any of these you can ask. Can you tell me how this might have affected you in your life? In any obvious ways or not so obvious ways? So this last thing would also help you find what meaning they have made of that. Then some other interview questions we can ask. Imagine you were a bird who could fly and look over your entire life. Right from the beginning till now, and you could fly back and forth as many times as you want. What are the things that you would find in your life? Then you can add whatever question you want to ask. What are the examples you're finding in your life where you're looking very happy? Anytime when you're looking lonely. Anything in which you're looking very scared. Anything you're feeling angry about. Anything you're feeling sad about. So you can use any of these hypothetical things. Imagine you're a bird. Then you can say, imagine you were born as a canvas, painted with unlimited capacity for creativity, genuine emotional experiencing, self-compassion, self-respect, authentic connections and growth. Like everything wonderful you add. Imagine you're born as this. What in your life you think might have been the experiences that changed this picture, that took away even a little bit of any of these. Or imagine you were a seed. You were born as a seed with immense potential, who just needed a conducive environment to blossom. And all the chances are there that you will blossom into this wonderful plant. The conducive environment that you needed was warm sunlight of love, protection from some storms of life, a wise gardener to guide your growth. What all did you receive out of this? And what all you wish was different? And can you give me examples? So I have put ellipses, the 3 dots, which means that you don't just say all the questions like a parrot. It's an interview, so you can ask and stay very, very, very attuned to the client, not in a hurry to just quickly fill your form or something. So when you're very attuned to the client, it will give you a very rich information. So I am just repeating here. We first ensure stabilization, only then we take trauma history. Even while taking trauma history, you pause as many times as needed. I repeat, even when you're taking trauma history, you pause taking the trauma history as many times as needed, and you first focus on stabilization. How we ask all these questions matters a lot more than what we are asking. So I have just made some of these questions which I showed you, but you don't have to ask all of them. And how you ask matters a lot more than what you ask. Use compassionate inquiry, use very respectful curiosity. So for example, can you tell me the 10 best things that have happened in your life? Which make you smile, which make you proud and happy. So again, when we understand that shame is a very predominant emotion that most of the clients and even many of us are, feeling stuck with. So finding instances of pride is very important. So ask for 10 best things in life which have made them proud and happy. You can even rate them. 0 to 10, how proud and happy did this make you? How proud and happy did that make you? What do people who like you describe you as? I have already told you. What all do they like about you? What all do you like about yourself? Now, when do we take trauma history? As I told you right in the beginning, you always take trauma history. Always means always. Some of these examples where you must definitely take, but when I'm saying always, then this is kind of redundant. But anyway, when there is treatment-resistant depression, treatment-resistant bipolar disorder, or treatment-resistant anything, you must take trauma history. That means someone has missed their trauma history. Chronic pain, medically unexplained pain, all somatoform symptoms, you look for trauma. Confusing, undiagnosed medical or somatic symptoms, substance abuse, any addiction of any kind. Eating disorders, definitely. Eating disorders is always trauma. History of turbulent relationships. Anyone says, I have this relationship in which I found an abusive partner, then another abusive partner. You have a very big red flag there. Patterns of emotional instability, any symptoms of personality disorder, these are at least the things where you will look for trauma, but everywhere you look for trauma. When the clients report any symptom, you can ask things like, how old were you when this first began? Which can be anything. Feeling anxious, putting on weight, smoking, drinking, taking the drugs, stealing, lying, feeling ashamed of your body, anything. What age were you when this first began? Client says, I don't know. Okay, doesn't matter. Any idea about any rough range? 5 years, 10 years, 15 years? Which class or which house? If they have shifted houses, then do you remember which house? But don't ask like interrogation. I am repeating, how we ask really, really matters much more. What might be the reason it began at that time and not earlier and not later? Usually it would be associated with any major lifetime experience that's happening, which may or may not be directly happening to the client. So I have a client whose father was drinking and drinking so much that he would be very often found in some gutter or the other, and some neighbor would bring him, and they were financially well off. Usually we see this kind of a picture with people who are living in the slum. That's a stereotype, but it's probably also true. And she was so ashamed of that. She used to never have any friends in the neighborhood. And very often the father would cut himself. And the father would also vomit blood. So she was mopping the floors many times. Now, she had asthma. Now she doesn't have asthma. It is so surprising. She is now 45 or 47 or something. All her life she's had asthma. Now it's gone. So when I asked her around what age her asthma began, so she told me some age. So I said, okay, what do you think was happening? So she said, no, nothing was happening to me. So I said, yeah, I didn't say what was happening to you, but what was happening in your life around parents, school, family? What was happening? Just tell me different things that were happening. So she told me, then she said, oh my God, now I realize how much stress I was going through that time. That my neighborhood friends had stopped talking to me, and I was all alone. And in the family, parents would be hitting each other, shouting and screaming, and she has an exam next day, but she would be studying somehow, and she performed very well always. This is also one example that, we think, oh, someone who has performed very well may not have trauma, but that's not necessarily true. So it's coming out now. She says, I was so well preserved till I got married. And after marriage, because she's not in that, her father also ended his life. So now she almost has, like, her body is able to now bring up the symptoms, so to say. I don't know how to put it, but earlier there was so much dissociation that all this was kind of stored away, and she was just performing. Anyone who says that, I am not affected by this, you suspect big time dissociation. A few more helpful questions, but you need to sensitively select. Do not ask all the questions, and do not ask like an interrogation. Try to ask what happened to you, what happened with you, rather than asking what is wrong with you. Ask rather than trying to figure out a diagnostic system. I know some of you are working in the psychiatric settings, and sometimes there's a pressure to find out the diagnosis, which is okay, but if you're doing therapy, then you need to focus more on what happened to the client. So look at it from the client's perspective rather than from the outsider's perspective. Can you also tell me 10 things that may now sometimes make you sad or scared? So look at how you have to soften the question. That may sometimes make you sad. You're not asking, tell me what all traumatic experiences you had. Tell me, did you have sexual abuse or not? Did you have physical abuse or not? So don't ask insensitively anything. Especially when you're sitting idle or you're trying to sleep. These are the times when people are sometimes bombarded with thoughts. So you can cushion the question like this. Or things which, when you hear about in others' lives or in the media, or you're watching something or reading a news about that, which make you slightly disturbed. There was a video which went viral a couple of years ago in which a mother was teaching the child, and the child is howling and crying, and it was supposed to be a very funny video. I never found it funny, but everyone was forwarding it. One of my clients sent it to me saying that this is so disturbing to me, and it's even more disturbing that everyone is finding it funny. I know the history of this client. Her mother used to throw her notebook down from the 4th floor if she doesn't stand first. So this is, if you ask her the 10 most disturbing things in her life, this was not among the 10 most disturbing things. But when she's hearing it in someone else's life, even as a funny viral video, then it is affecting her a lot. So that's also a way of looking at, whether we are affected by something or not. Is there anything you wish had never happened, especially in early childhood? we all may have some things. It's, sometimes you have to cushion a question like this. We all may have some things in our lives that we feel ashamed about. Is there anything like that for you? And you don't have to tell me what it is right now. So don't say you don't have to tell me right now, but tell me later. What if they don't want to ever tell us? Which is okay. So, but is there shame is what you're trying to ask. Is there anything you wish or try to not think about, or you wish to forget? You wish that it never came to your mind? And again, it's okay if you wish to not tell me right now or ever. But basically, they are trying very hard to suppress that. So that would give you an idea that there is trauma which they're trying to suppress. What do you do for this? And it may be any addictive behaviors, which may be, just mindlessly scrolling the phone, which is what most people are doing nowadays. It's a mind numbing activity. If there were 3 things you could change about your childhood or life, what would they be? This is called the 3 wish test. We do this with children, but you can do it retrospectively also with adults. Now, assessing for sexual abuse is also very important. Many people may not be able to tell us, many people may not remember, the concept of recovered memory is very well known concept, so I assume all of you know. So it's helpful to ask, would you like to tell me about your first sexual experience? But again, be sensitive about when you're asking, how you're asking, and you don't have to ask only when everything is stable, or they might tell you. So instead of asking whether were you sexually abused or molested or harassed, that is a very insensitive way of asking the question. Very often clients have guilt or confusion about the sexual abuse because they say, I only asked for it, or I kept going back, or I used to enjoy. So then you can say, I hear you saying that you did not resist the abuse, or that you went through, and in fact maybe you enjoyed it if they have said that. I'm just wondering if you would expect whatever age they say I was. I have a client who was 9. So she and her cousin used to do some rubbing against each other, a female cousin, and she used to feel so guilty about it. So I would ask, I'm just wondering if you would expect a 9-year-old child that you see around, and you have any younger cousins, so you have to build it up. You have any younger cousins? She has younger siblings. So I said, do you remember your sister, your brother when they were 9? So would you expect them to actually be able to stand up for themselves, or actually understand what is right or what is wrong? Or especially, would you expect them to resist against an authority figure? And if not, would you blame them for the abuse that they went through? So usually lack of self-compassion, then people may be blaming themselves, but when they see another child, 5 years, 7 year, 9 year, whatever age, that they're able to say that, they are very young, they may not know and they may not understand. So it helps to get a little more self-compassion through that. This I will not go through. There are lots and lots of standardized measures for trauma assessment. You can find them easily. This is just a saying by Viktor Frankl, which I'm very fond of. An abnormal reaction to an abnormal situation is normal behavior. So when you're doing the interview, keep this in mind and validate several times and in detail. Validating once is not enough. Validating just by saying, I understand, is not enough. You need to elaborate on what you understand. Now I have a few questions to you and then we will stop. So, and I want you to please respond. You think it would help to ask, so do you still feel disturbed by that experience? You think this is a good question? How would it help? Is it not a good question? Yeah. Anybody?
Ma'am,
It doesn't seem to be a good question.
Why?
Because we are instilling this idea that you shouldn't be feeling disturbed now.
Absolutely. Absolutely. Very good. So even if you're not saying that you should not be disturbed, but by this question, you're kind of implying that. Okay. Now I have another question. So while I'm talking to you about interviewing skills, is it a good idea to ask all these questions if I'm not sure what to do after asking all these questions? Yeah.
Most probably no.
Why?
Because as a therapist, we should be sure whatever we are inquiring, we are accessing their memories of their childhood and their past. So, associated with the positive emotions, there can be also an understanding what might have been neglected or missed out. So, that awareness can also come in for the client. So, we have to be very sure how we are going to go ahead with the information that is being given to us, right? And what we'll be able to find the client to do with that information in the coming sessions.
So if I'm not trained in therapy, it's not a good idea to ask all this. If I'm not trained in how to process that trauma.
Yes.
Okay, good. Last question. When the client is describing in great detail about the traumatic experience of the past or an ongoing traumatic experience, it is important to keep listening to them. True or false?
Depending on when this is happening. If it's happening in the first meeting with the therapist, probably not. As you mentioned in the beginning of today's session, that it's important to interrupt and pause and stabilize before going forward and cushion the client. And if it is happening during the second or middle stage, right? So we have done the base work of how to deal with the after effects of retelling of the traumatic experience.
You think one session is enough to do stabilizing, skill building, resource building?
No, ma'am. When I'm saying stabilizing, I'm expecting there would be few sessions, minimum 6 or 7, depending where the client journey is. And maybe the stabilization has to happen beyond those sessions too, in the middle or while we're terminating sessions too.
Yeah. So no matter you've done how much stabilization, if the client is describing in great detail about a traumatic experience, it is not a good idea to keep listening to them because it is usually re-traumatizing. You can see that, when they are talking, they may be crying. You can see they are hyperventilating. They are probably shaking. So it's not at all a good idea to continue listening. Okay. Instead, you need to find ways to help the client ground and stabilize. And focus much more on grounding and stabilization and resourcing. Because if they are telling you so much, that means they are thinking about it throughout the week before meeting you. Okay. So these are just a few additional suggestions. Always keep hope and instill hope. No matter what. No matter what is very important. No matter what has happened. Always keep hope. Always instill hope. So having struggled with their symptoms for years, clients would often have despair and even hopelessness. Acknowledge client's perspective, but do not reinforce or ally with the client's hopelessness or helplessness. Sometimes we have our own hopelessness and helplessness in our own life situations. And if we find a client has slightly similar life story or very similar life story, then it becomes doubled hopelessness and helplessness. And that is not good. That's a very good indicator that we need to go for our therapy. Or if we are already going for therapy, then we need to probably wonder whether this therapy is actually being effective, if it is regular enough and effective enough. The therapist can reframe pain as awareness, but this I will avoid. Hope is something which you have to instill. Now let's do one small exercise. Suppose the client says this phrase or this sentence. How can you rephrase it is the exercise. So the client says, I don't want to get better. Now come on, let's all try to rephrase.
Do you mean you're afraid of confronting difficulties during the treatment?
Okay. Any other possibility? Can we say sometimes it does seem like we don't want to get better? Or sometimes just because we have not yet felt better, maybe directly or indirectly by the others or by ourselves, we feel blamed that we are not trying hard enough to get better, so we don't want to get better. The fact that you are here means that you want to get better and you deserve to get better. Yeah? Second, I like to do overthinking. I like to do overthinking. If the client says, I like to do overthinking, we will say, yes, I think you like to do overthinking, right? No? What would we say?
We can probably say that it seems like it stays in your head for some time.
Good. That's much better than I like to do overthinking. We can also say that something has been so disturbing to us that it keeps coming to our mind over and over again. I'm not sure how much you're doing this intentionally. When you say, I like to do overthinking, it's like saying, I like ice cream. Are you saying that it is like that? So you can, very little you can use humor also to show that it's not that something that they like. I enjoyed abuse. So, but we have covered that. We can probably skip this. I am useless. Yeah. How would we rephrase? Come on.
You feel that you are not worthy enough. I mean, do you feel that you are not?
Is that a feeling or a thought, first of all?
Thought.
So you think that you're not worthy, and yeah, go ahead. It seems like you have a belief that you're not worthy. Some of our beliefs are facts, some of our beliefs are not facts.
We can also like question. I'm wondering what is making you question your usefulness or making you question about you.
That we can do, get into an analysis and discussions. But right now we're just trying to rephrase, Sometimes very low self-esteem, a lot of shame that the client has inherent. So how can we just rephrase? I have no hope.
It looks very dark ahead.
Okay. Right now it seems like it's very dark ahead. If you just add the word right now, how does it change?
It brings it to be like a momentary reality rather
Yeah,
than
rather than a fact, right? Rather than an eternal truth. I have never done anything right. Others can also respond. I can only see everyone's backs. How would we respond? I have never done anything right.
We can add humor. You came for the therapy session, so it's the right step you have taken.
Okay. Okay. Fine, that is one possibility. You can even little bit just emphasize. You're saying you have never ever done anything right. Really? So you are very gently confronting, because it's not possible that someone has never done anything right. So if they just hear these words, they'll be able to say, no, I have done a few things right. That's all. You're just, that all or none thinking, you're trying to shake it. Then other things, I do not try hard enough to get better. You are trying what you can try given your circumstances, and I'm really proud of you, or I appreciate, or I'm very happy that you are doing this and this, and be specific about what they are doing. I want to quickly get over the trauma. I do not need stabilization. I know that's how it seems like, because we are so tired after years and years of carrying this trauma. Oh, we wish we could just get over it and we didn't have to wait for stabilization and this and that. I get it. So you're just validating. You're not agreeing. I grew up in a perfectly loving family. It's only the multiple abusive romantic relationships that have hurt me. Yes, I believe that, you've had many abusive romantic relationships and you've deserved much better. And it's possible that this has happened despite a very loving family. It's possible that we were too young to see how we are feeling. It's okay either way. So you don't have to agree with it. You don't have to disagree with it, but you can just stay with it and rephrase it whenever possible. Or maybe later, not now. Never communicate these things in an attempt to instill hope. Get over it. It's been too long now. Put it behind you now. You're so affected by this because you are weak. This is a very common thing. Oh, this, people say, one mother was telling her daughter, who's my client, I went through so much, but I am so strong, I did not let it affect me. I did not let myself get depressed, and implying that she is very weak. Many have gone through much worse. If we say that to the client, I have also gone through, and then do some self-disclosure, and so what? Now, I have a question. Suppose we don't say these, because we have common sense to not say these. Most of us have enough sense to not say these. But suppose we think this. Suppose we believe any of this. Do you think it is likely to affect the therapy process? Yes, no, don't know. Huh? Don't hear anything.
Yes.
Yes, it would affect.
It will affect the therapy.
Yes, absolutely. So if we believe these even within our head, they will affect the therapy process. So when we are interviewing, it's very important to have consistent boundaries, which is part of not just the interview, but the entire process. Avoid self-disclosure. Your interview should not involve, oh, this happened with you. I'll tell you what happened with me also. Don't do self-disclosure. That is our need. That is not the client's need. Sometimes it's possible that the client's life story triggers us, or it is very similar to our life story. That is just an indication. I have already said this. It's an indication that we need to go for our own therapy. Going for therapy is a privilege. It is not a sign of mental illness. I really respect people who go for therapy. I go for therapy. I've been in therapy for years. Right now, I don't have a therapist. I wish I could find one. Many of our clients have grown up in inconsistent environments. So when you are meeting, so see, interview is not just what's happening. Interview is also your setup. Sometimes we don't fix up the appointments. If you're doing therapy, you need to fix up an appointment very consistently, ideally on the fixed day, fixed time. That kind of consistency and predictability in itself is therapeutic over a long period of time. If we don't fix appointments, usually people will start treating the therapy session as a crisis intervention session. Only when we are feeling very disturbed, we'll come for sessions, otherwise we won't. And then you'll say the client comes and they start crying and weeping because they are obviously, when they are not coming regularly, crises are likely to happen more often. So these are just various points to say firm boundaries are very stabilizing and very important. And with that, I stop my presentation and I'm happy to respond to any questions you have.
Ma'am, firstly, thank you for such a illuminating and lucidly explained, explained a session with us. For us as practicing clinical psychologists, I believe we sometimes miss out on the basics when we work with trauma. So this was very much needed. Ma'am, however, I have one question that was nagging in my mind. Many times clients, even if we are prepared and we are doing stabilization and we are starting the conversation around their experiences, sometimes, many often they come up with the response, I don't know. And they kind of stick to that narrative, no matter how many times we are assuring them or we are taking a different probably approach. How do we navigate that? If you can
you give me one example?
Ma'am, for example, if suppose one of the positive experience questions that you had posed to us. So this happened in one of the cases I had come across quite a few times back. When we spoke about, who was the person or when did you feel safe in your childhood, or whenever we speak about the concept of safety, they're unable to recall. And I understand that's where they are not able to. Yeah. Stress is happening, but they come up with they say, I don't know. I don't know. And even if I ask you, okay, how are you feeling right now? I don't know. So a lot of I don't know responses come about. So how do we go ahead from there?
See, this how are you feeling right now is a question which has been beaten to death by all of us therapists. And sometimes clients come and make fun of this question also, that, I went to 5 therapists. They keep asking, how are you feeling? How are you feeling? And in different tones, they keep asking. And so that is, so, we need to also ask different questions or sometimes make statements that, maybe in the situation, I might feel a little bit like this. I wonder what happened with you. You can ask this. You can ask slight, we don't have to be like a parrot repeating the same question in that sense. About whom you felt safe with. See, the context really matters. Suppose the client has told us about how they felt unsafe, right? And suppose we are asking, so whom did you feel safe with? Sometimes clients will tell you, my clients have told me that, when you used to ask me questions about whom you felt safe with, whom you had fun with, I always thought that you will say, see, there were so many people you had fun with or you felt safe with. Why are you focusing on this person you felt unsafe with? So the context really matters, and you need to say that, so we usually have a mixed set of experiences, and of course that even if a small, so I emphasize on the difficulty, so one example which I have used so many times, I'm sure some of you are my students and you may have heard this example, that even if you have a small dust particle in one eye and you don't have a dust particle in the other eye and all your hands, legs, everything is fine, why is it that our entire attention is on that? Why don't we say, oh wow, such a lovely weather, oh wow, this is such a nice color, or something or the other? We are not able to say. So if you make one of these statements that, it's very understandable that even if one thing has not been okay, and you have told me so many things which have not been okay, obviously our attention goes there, and that's very normal and understandable. So they will not think that you are about to say, oh, why are you focusing on this when you're asking, when, somebody you've been safe with also, why don't you focus on that? So the context matters.
Okay. Thank you, ma'am.
Thank you.
Anyone else questions? Questions, anyone?
Anyone has any other questions to ma'am?
That means people were either sleeping or they have understood everything.
Yes, ma'am. Thank you, ma'am, for this detailed, insightful session. We all talk about structural intervention for trauma care, trauma and related trauma-based interventions. But in this session, we get to know very detail about how to conduct the interview, how to do the assessment, because these are the most important area. Without this, we just cannot go for the intervention part. Thank you so much, ma'am. This is such a very, very enlightening session.
Thank you very much. My pleasure. Okay, may I leave?
Yes, ma'am.
All right, thank you.
Thank you, ma'am. You will receive a Google form soon within 1 or 2 minutes for this particular session. Okay? Sure. So now, after this session,
No, offline. This is offline. Yeah. So yeah, so we can start the session.
now I would like to call our guest speaker, Ms. Sampurna, for our next session. Sampurna has completed her MPhil in clinical psychology from Institute of Psychiatry, Calcutta. She has completed her PhD tenure from Central Institute of Psychiatry, Ranchi. She is a trauma-informed therapist. Please come.
Okay, hello everyone, and so my topic is understanding psychopathology through trauma lens, and I think it. I mean, since the morning there has been so many discussion and two major sessions, so maybe a lot of things that I'll talk about might be a little overlapping. So I will keep that part short, and I'll mainly try to focus on the psychopathology part. So these are the main things that we talk about. So understanding what trauma lens is, which is again something that has been discussed. How different does psychopathology look through trauma lens? So when we use a trauma lens in our approach in the assessment or the interview or intervention, so how does psychopathology look different, or why is it important to see it through a trauma lens? And I'll briefly talk about these majorly about depression, anxiety, and how it manifests or psychopathology looks like through trauma lens, and briefly about dissociation, and just mention about the other conditions which can also have you can understand the psychopathology of other clinical conditions also from a trauma lens. So to start with, since the morning we have been discussing about what trauma informed care is, or what the trauma informed approach, or how to have that approach in assessment or intervention. So now that I'm asking, I want to know what do you think is your understanding of when we try to say that we are trying to understand the psychopathology through trauma lens. So what are we exactly meaning by trauma lens? So it's basically a perspective or an approach or a framework, but what does this approach or the framework talk about, or what does it imply? Anybody? Okay. Right. So whenever we are seeing a symptom, seeing it as a symptom of depression or anxiety, or if we are seeing it from a trauma lens, then is it possible that trauma has contributed or has an impact or a role to play here? So it's basically, as I said, it's a framework which is grounded in the understanding of the psychological and the neurobiological impact of trauma. So as in the first session also it was discussed, and in the second session, so it does leave a major imprint on our brain. It changes the brain mind body connection. There's a major neurobiological impact that trauma, any kind of trauma, leaves behind, right? And the similarly is the psychological. We'll talk about that in detail. So to recognize that how a particular traumatic incident can have a lot of neurobiological and psychological impact in an individual's life, and this could be because of any traumatic experience, right? So, and it can happen also across the lifespan. So in the previous session we were talking about how it's important to talk about or inquire about the attachment. So it can happen across the lifespan. So something that has happened traumatic in maybe the formative years, and later in adulthood we see a clinical condition, and is there a possibility that these two things can be linked, even though there's no temporal connection immediately, but try to see it from that framework, that can the trauma or any kind of major life event during the growing up years or at a different developmental age can be the cause of something at present, right? So what it mainly acknowledges is to acknowledge that trauma can have a profound impact on our physical health, emotional health, mental health. As I said, it's a neurobiological and a psychological impact it has. It can be one of the contributing factor. It can be a causal factor. It could be a maintaining factor, or it could be a major factor in exacerbating the symptoms as well. So seeing trauma, using a trauma lens to understand psychopathology is not just restricted in understanding that is trauma a cause of the disorders. So when we study about the different clinical conditions, we always see in etiology there is always a point which mentions about how trauma can also be one of the causal factor. But it is not just the causal factor, but it can be also something which exacerbates the situation. It can keep on maintaining if there is a major traumatic experience and that is not being addressed, so even if the person is taking medication or intervention is taking place for that person for the other symptoms, we may not have adequate treatment outcome as expected because the trauma is maintaining the psychopathology at some level. So that is why it's important that we have a trauma lens perspective while we are viewing any kind of psychopathology. And if you see, there is hardly any disorder where you will not find that trauma can play a role. If not a direct link, it might just increase your vulnerability, or it might just interfere with your resources, coping resources, or it can be, we also talked about how so many of the physical symptoms, physical disorders are also linked to trauma. So as I said, it's as a causal factor, symptom expression. There's a huge concept of reenactment and the re-victimization. So this, if we understand the neurobiological perspective, it's easier for us to understand that a person who has experienced a major traumatic incident and has the core trauma symptoms, it is very obvious, or it's very common to see that the person will be in that survival mode, right? The HPA axis is always overactivated. So that kind of makes the person more vulnerable to constantly have experience of reenactment and re-victimization of the traumatic experience. And that again might be a maintaining factor or cause newer psychopathology or even exacerbate whatever is the existing psychopathology. And trauma always can add to as a comorbidity, and as well as to have the trauma lens. So as we were just discussing that, we should be inquiring or assessing things that we are going to address in our intervention. So if we are using a trauma lens and if we are trying to understand psychopathology through that, then it's essential that we also incorporate that in our intervention. Otherwise, it's just one way of seeing it at a theoretical level, but we are not applying it. So these could be the major reasons or the ways that can help us using a trauma lens to understand psychopathology. The neurobiology of trauma has been explained, but I just wanted to talk about this so that we understand how the anxiety or depression can be conceptualized through trauma. So as we all know about thalamus being the relay station, so whatever the information is coming, that is the source, and it's very obviously, it has detailed pathways and all. It's a very simplified explanation of this. So there's a two route, one I think most of you are aware of. One is the shorter route and the longer route. So till it goes to the longer route, that is the frontal lobe, which is associated with functions, executive functions, so about judgment, about the understanding situation, logical thinking, reasoning, that is the longer route. So whenever there is what we were talking about, the reenactment or the re-victimization, so whenever there's a trigger, whenever there's a situation which some way resembles the situation, the traumatic incident that the person has experienced earlier, it may not to us appear that these two situations are not even related. But to an individual who is experiencing severe traumatic symptoms or is going through that kind of a phase, it's that person can relate the two things with just a simple memory, which is similar, or by some cognition, or just the thought that I didn't have a control in that situation, I don't have a control in this situation, even though the two situation is completely different. So just with the thought of that need for control, you go back to that phase where you think that again a traumatic experience is, you are going through that, and it's a reenactment, and it's not that, it could be a false alarm. Similar thing happens when person experiences flashback. So for us to see, it might appear the person is having flashback, but when the person is having a flashback, the person is actually experiencing that it is happening with me yet again. It's not something I'm thinking of something else. That very moment, it seems real. It seems actually happening. That is why we use grounding techniques for flashback. Once that phase, for that few brief minutes, it's passed, then the person also realizes. But then that impact is there. But while the flashback happens, the person doesn't realize. So there's a lot of time, there's a false alarm system that goes on. Right? So we were talking about the book that the body keeps the score. So this is something that was explained in the book, which was really nice. So I thought I'll share it with you all. So it was said that the thalamus is like the cooking station. So you have all the ingredients and everything, and you are cooking there, right? And the fact that the information that something is getting cooked, that some information is there. Now that there's obviously fire in that cooking station. So now, because of the shorter route, the limbic system, mostly the amygdala and the hippocampus, which has the trauma-related memories as well, and the emotionally laden memories, it, without understanding what is the cause of the fire or why I can see the fire, raises the fire alarm, which many a times can be a false alarm as well. But it is not possible for that person at that point to understand that. And the prefrontal cortex is the watchtower, which, because it's a longer route, it sees, understands the situation, and after a period understands, oh, this was just a false alarm. But before that, the person might have experienced panic attacks, the person might have experienced a flashback, or it's just a state of anxiety that the person is experiencing. And that again has an impact. And if a person chronically or persistently keeps experiencing this false alarm route, the person maintains, and the HPA axis is always activated, which keeps that person always hypervigilant, makes the person always engage in certain avoidance behaviors, certain safety behaviors, which again maintains the same loop. So this was, I wanted to share this. So now, from the psychological mechanism of trauma, so why does, now neurobiologically, that's how it gets maintained. So if we try to understand psychologically how it gets maintained, so obviously this adverse childhood experience, which is very formative, and with recent research, if you think from the neural plasticity, those experiences are very important for our development of our brain, right? So it could be any kind of experiences, like, so quite until recently, it was understood that major life events like disasters or major accidents, war, combat, abuse, rape, these could be the major reasons of trauma. Now, with the understanding of complex PTSD and its inclusion, even emotional neglect, deprivation, invalidation, or very mixed kind of an attachment or an insecure attachment, all of that could also develop a trauma response. Now, what happens is, we may not see typically like, because of invalidation or neglect, you won't see a person maybe very commonly develop PTSD or even acute stress disorder. But what it creates is a trauma reaction, a trauma coping. So that is the way you always process information. That is the way. So you can't see things from a different perspective, right? So these could be some that develops, gives rise to our core beliefs. Now, these core beliefs with the situation, again, each person has experienced trauma once or sometimes in their life, and there is always stressors around us. So these stressors start working on these core beliefs and starts giving rise to this conditioned assumptions, right? And this assumptions, will give rise to this kind of behavior, which we essentially see as trauma response. That is, either there is an excessive dependence on a person, or there is complete mistrust. There is a lot of anticipation that this might happen, that might happen, because of that constant HPA axis activation. So because of that anticipation, the person is obviously taking much more amount of stress and anxiety. There's a lot of attempt and need to control, because so trauma is what it's basically is like, where it could be, when we were talking about that, is there a particular incident only that will be considered as a trauma incident, or it could be anything else, anything that is traumatic to the person. So if you talk to any trauma survivor, they always talk about that, how that situation made them feel very overwhelmed, how that situation made them feel completely out of control, that they had no sense of agency or control over their life. That is why it was so overwhelming, and they don't know what to do about it. So from there, it comes this anticipation, this tendency to always have a control, have a need for control. So if you see patients who have had, like maybe somebody who has currently presenting with complaints of clinical depression, but if you take the history of trauma and you see that there is And you might see that this person, when you do a person, assess the temperament or a premorbid personality, you might find some traits of, I'm just giving an example, that you might find traits of anancastic personality. That this person has this excessive need of planning and anticipation. There's an excessive need to control and keep everything the way that I want, a lot of things. But the same thing, it is also possible that it is a enduring personality change due to trauma that now manifests as anancastic personality, you know. So that this maintains the trauma reaction. It may not show as PTSD or in complex PTSD or any other trauma related diagnosis, but keep showing in other clinical conditions. So as we were talking about the hypervigilance, the role of HPA axis, I think, is known to all. So it will always keep the sympathetic nervous system activated. So you always feel there's an emergency that you have to act on. So you always have that sense of that you're feeling on the edge, right? That something immediately might happen. I need to do something. Impending danger is there. I need to react that way. So I need to be always on an alert stage. Right, so that is obviously related to panic disorder, generalized anxiety disorder, could be related to social anxiety, many other anxiety symptoms, right? So they also, you'll see the anxiety patients, they will often always engage in a lot of avoidance and safety behaviors. So the reason is that obviously they don't want to experience that kind of an hyperventilating state or go into that ruminative stage, and that's why they try to avoid or engage in safety behaviors. But as we know that because that trigger will be there, and the more you try, the entire concept of the exposure and response prevention, that if you try to engage in avoidance or the more you try to engage in safety behaviors, this you are maintaining this anxiety loop. So because of that, so one, trauma can make you more hypervigilant, which can make you feel more on edge or more anxious about things that is happening around you, more anticipatory, more apprehensive. And it also, this is something causal, and the reason that after anxiety develops, the way you will keep engaging in different types of safety behaviors or different types of avoidance behavior, that will kind of maintain it. And because you have this activated HPA axis, any kind of stressor will always increase or exacerbate your experience of anxiety, right? So this is how the psychopathology of anxiety can be seen through trauma lens. Like, this is how trauma can cause and maintain or exacerbate anxiety. I think this is what I was talking about, that when there's a traumatic event, the most commonly that we see is that hypervigilance, rumination, intense emotions, flashbacks, and that kind of maintains you to, and compels you to engage in these symptoms, that is avoidance, reassurance seeking, safety behaviors, which maintains this trauma anxiety loop. And that's why even if you are addressing the anxiety, you are doing a CBT for maybe GAD or CBT for social anxiety, and if you're not addressing this trauma response, that why you are always responding to situations like this, or why or about the cognitive errors, you know. So if we see it through this lens, then we can also have a perspective that how trauma can have a causal and a maintaining cause factor in anxiety and anxiety related symptoms.
Patient feels that the patient is experiencing certain symptoms. Like, for example, there may be a sudden need for craving for sweets, or the patient might be like, you know, the patient is shopping. Now, the patient feels that he or she is shopping a lot, which may not be happening according to others. Is this also like part of trauma that the patient had undergone while he or she had depression, that she or he may be reliving right now? Or is this like psychosomatic, and, you know, the patient is kind of thinking that I may be having depression again because I'm under stress right now? Is that?
Yeah, so I'll be talking about depression now, but to answer your question, I think because we all have this essential individual difference, so I think the trauma responses can also be equally different. So it's very, I think, unfair to say that if a patient is reacting in this way, this could be because of trauma. Definitely it could be, but that's not the only way to look at it. I mean, that's why I'm saying that this is just a perspective. And when we are doing clinical practice, it's essential that we are aware that if whenever necessary, we take this perspective so that we can look at things that way. But again, it has to be seen from a contextual and a holistic way. Like if it's just about the example that you gave about shopping, like if it is a very pervasive pattern, or is it a very temporary thing that a person has recently found out a good coping and is managing well or something, that may not be linked to trauma as well, or maybe again.
What I was trying to ask you was, can this be a form of anxiety that the patient is experiencing because the patient is over magnifying certain things that maybe he or she did while he or she had anxiety?
Definitely.
So
Yeah,
that could be part of anxiety. It's not necessarily like, a trauma. It's more like anxiety that the patient is being hypervigilant.
yeah, but then the reason why that person is magnifying this thing could be because of trauma.
Okay.
That is what I'm trying to say.
Thank you.
So moving on to depression, what we were talking about anxiety, the same mechanism might be applicable for depression, and a lot of anxiety is part of depression, right? But the major thing, the way that trauma can impact or have a role in depression is the trauma related beliefs and cognition, right? So in depression, the very commonly we see there are many faulty belief system. There could be a lot of faulty assumptions, cognitive biases, errors, behavioral responses arising from those cognition. So like some way it could be like the negative automatic thought, so you have a biased thinking because of your trauma that if somebody if this had happened with me, this is how it is going to be. No, I can't see it in other positive way. If like a person who has experienced maybe immense amount of emotional neglect while growing up, the person will always have a biased thinking towards any form of interpersonal relationship. When it comes to so obviously when you have those thoughts, that will obviously lead to your feelings. Now the low mood or the fatigue or the disinterest, lack of losing interest, all of that qualifies as the depression or the diagnostic criteria or the clinical symptoms. But what is probably leading to this way? Like why is the person losing this interest, or why is the person engaging in so much of avoidance behavior? So you will see there's this very common thing that very severe or very chronic depression patients say, I can't remember when was the last time I was fine or I felt good, or I can't remember feeling any different ever. So the trauma memory may color it in such a way that you never see a time when that people were not unfair to you or things didn't happen wrong with you. So you end up overgeneralizing or magnifying or catastrophizing and all of that in that similar way. Similarly, you will obviously have a lot of self-criticism or rumination. So again, because of trauma, there's a huge amount of guilt, shame, self-blame that also may result in a lot of your perception of the self, your perception of the world. And as a result, the way you see everything or the way you're responding to things around you, that will be, which shows as the depressive symptoms, could also again be caused or being maintained or exacerbated by trauma. Right? So dissociation, I think it's quite detailed discussed in the first session. So there are multiple recorded cases how after a trauma a person has experienced the concept of dissociative amnesia came from that. There is multiple cases of dissociative fugue, dissociative identity. There are several movies that has been made showing that how trauma has resulted in dissociative identity. Derealization and depersonalization are very common symptoms, or these are very common in every kind trauma patient. So dissociation as a symptom and dissociation as a clinical condition, both could be caused by trauma or maintained due to trauma, right? So what I'm trying to highlight here is that you may not always see that that because of trauma, this is PTSD or complex PTSD or acute stress disorder or adjustment disorder. It could be any other psychopathology, but trauma may be a major role, may play a major role in that. And when we are planning the assessment or the intervention, it's very important that we use the trauma lens. So these are different trauma reactions which you might find in many other clinical conditions. And we tend to see it only from the perspective of depression, or try to conceptualize from CBT or whichever mode of therapy that we are using for depression or for GAD, but we don't take the consideration always of trauma, right? So that is the perspective of trying to see psychopathology through the trauma lens. So these are some of the different reactions that we see, again, not being clinical conditions, but they are very much a part of the psychopathology. So the difference between psychopathology, understanding the psychopathology, and giving a diagnosis as per the criteria. So that is what is important. Now, these are some of the other conditions where we can get to see a lot of trauma response: body dysmorphic disorder, eating disorder, excoriation. There's a lot of adult ADHD cases that comes up these days. And there are reports where they say that even though the manifestation or the picture looks like ADHD, the history is not adequate from childhood that suggests also ADHD, because ADHD is a neurodevelopmental condition. So there should be symptoms some childhood, but in adulthood that symptoms start showing. This could majorly be due to trauma. And if you see CPTSD, the criteria and the psychopathology has a huge overlap with borderline personality and with ADHD. Substance use disorder is already discussed, and insomnia. So how do we exactly use trauma lens in the clinical practice? I'll come to you. So first is what was discussed, how in assessment we need to keep that in mind. So we have to inquire about trauma, right? Like how we do in suicide assessment, there is a lot of myth that if you ask a person about suicide, you might be giving those ideas, but that's not true, right? So similarly, it is very important to inquire about the trauma, the experience of trauma. You need not know what is the traumatic event in detail, but the experience, so that you understand the person's personality from that perspective, the person's coping, the person's cognition, behavior, interpersonal relationship, the self-image. All of this could be related to the trauma. So to understand that, we need to do a very detailed clinical interview, but make sure that you give a disclaimer or you take consent about it, that I will be talking about or inquiring. It's a part of the routine discussion, but I would like to know a little about that. So if you are comfortable, if the person is not comfortable to talk about in the first session or second session, but make sure that that's there in the plan. And to include that, it's very important that I just take the history of the trauma and then I don't include that in my conceptualization or in my psychoeducation. Then there's no point of seeing psychopathology through trauma lens. And when we are doing the conceptualization, to explain to the person that, like how you were saying that this is how I can't trust anybody, or I don't think that I can trust anybody ever. Why you think so? So when you explain it from a conceptualization, or even when we talk about in the part of psychoeducation in certain conditions where it's important to assign a sick role, so when you can give that understanding to the person that the way you are thinking or the way you're behaving or you have been doing so could also be because of trauma, and it's not essentially something very fatally wrong with you, that can itself serve a huge therapeutic purpose. And then obviously after you have done the conceptualization and the psychoeducation using the trauma lens, whatever your findings are, and you discuss that with the client, then to plan accordingly whatever your trauma informed intervention is. Okay, so any of your client, any patient that you can think of who you have conceptualized earlier with their clinical diagnosis, try and if possible try to take a history from trauma and try to conceptualize from trauma perspective, from trauma lens, and you might find it useful. Thank you. Yeah.
Thank you, Sampurna, for such an interesting overview about understanding psychopathology through trauma lens. Thank you very much. Somebody had a question? All right. Okay. We have tea served outside. It's going to be at the same place where tea was in the morning. And we have one more session after the tea. So if you can just trickle back quickly in 15 minutes, then we'll kind of wind up early also. So please have your tea and trickle back as quickly as possible. Thank you.
No, I just have one important.
All right. Before we begin our next session, I'd like to request Dr. Rushi to kindly facilitate Ms. Sampurna with a token of appreciation for her lecture. Dr. Rushi, please. Thank you. Thank you, Sampurna, for taking out time from her busy schedule. Now I'd like to request Ms. Neha. Ms. Neha Das is Assistant Professor at Amity University, Noida. She has completed her MPhil in Clinical Psychology from Institute of Psychiatry, Kolkata, and is pursuing her PhD in Clinical Psychology from Central Institute of Psychiatry. Her interest area lies in children and adolescent psychiatry, dialectical behavior therapy, and trauma-informed interventions. I request Dr. Ms. Neha to kindly come and deliver her lecture. Thank you.
Hello, everyone. Good evening. Throughout the day, we talked a lot about trauma-informed care, various trauma interventions. Now we are going to focus on attachment injury in the context of trauma or vice versa, and how it plays a role in the development of trauma and again the attachment dysfunctions. So these are the contents I will be covering. Mostly is that understanding of trauma, attachment, theoretical perspective, how attachment styles and cognitions are interplaying, what is the concept of secure bond and the quality of relationship, because we always talk about negativity and we always talk about the dysfunctions, but what about the secure bonds? Next, we will be talking about attachment trauma and the related terminologies which are very important in this field of research. Then we will be talking about intergenerational transmission of trauma. I think someone asked these questions in our earlier session. So we'll be discussing this thing over here. And then we'll be moving to adult attachment model. And I will just point out evidence-based management. I am not going to discuss because we already know all these things throughout the day. Okay. So as per the current epidemiology,
70 to 90% of people may experience at least one trauma during their life. 20% of people who experience trauma may develop PTSD. So it's like not all trauma experience or all trauma survivors are having the diagnosis of PTSD. But yes, if it is a PTSD, then definitely there is the trauma. Treatment is effective in reducing symptoms and their severity. Out of the sample population, 1/3 never see full eliminations of symptoms at the means of recovery or remissions. And half of our people, PTSD, also meet the criteria for substance use disorder. These we all know the basic 4 F's of trauma response. I'm not going to detail about it. Now we'll be talking about attachment and how these are connected. So talking about attachment, first is safe haven. What is safe haven? The attachment figure where we can go or where we can seek any kind of help at the time of crisis. Next is the proximity maintenance. What is proximity maintenance? It's like how close we are connected to our attachment figures or relationships who are there in our very close proximal zone. Separation distress is about when the child experiences that my mother is going to leave me, that typical separation anxiety thing. So when we talk about attachment, it would be unfair that we don't mention about Bowlby. We all know about Bowlby. Just a touch upon it, that Bowlby has focused on the pre-attachment styles, from pre-attachment to the multiple attachment with multiple caregivers. Next is Ainsworth, who basically talked about secure attachment and insecure attachment. And among insecure attachment, there are anxious avoidant, there are anxious preoccupied, and disorganized pattern of attachment. I guess we all know this because we have all read all those things in our post-graduation and graduation syllabus. It's just the recapitulations of earlier theories, because other than understanding the early child attachment, we cannot actually move into the adult attachment, and trauma is everywhere, be it early or be it adult attachment. Next, we'll be discussing how these attachment styles are functioning based on the anxiety situation or the situational distress, and how my perception about myself and my perception about the others. Okay. So we can see over here that if my avoidance pattern is low, and if I have high anxiety and I have negative self, like low self-worth or the pessimistic view about myself, then we kind of have that anxious preoccupied attachment. When we talk about the positive model of self and we have the low anxiety, then only we can talk about the secure attachment style. The other two are again comes under the insecure attachment. One is avoidant and the another one is fearful, which again encompasses negative models of others and high avoidance behavior pattern. Next, we will talk about what is secure bond and what is the quality of relationship associated with secure bond. So these are the basic questions we all ask ourselves, or we all ask the partner or the caregiver or the attachment figure, especially in the crisis time period. Like, say for example, some interpersonal crisis is going on and one partner can tell the other one that, can I count on you? Can I depend on you? Can you support me on my crisis situation? So this kind of expectations and all, these things are going on. Why this kind of questions? Because the partner expects emotional accessibility in terms of wherever I am in crisis or any trauma situations, is anyone available just to listen my thing, or is anyone available where I can actually ventilate, Okay, this is the emotional accessibility. What is responsiveness? Whether I am gonna respond to that crisis or not. Someone is asking my help, whether I am gonna be there or not. And that completely depends on the how the attachment bond. See, for example, there are two person. I have close attachment with one person and I have a very acquaintance kind of bond with the other person. So obviously, based on the attachment, my response also will be altered, right? Third one is emotional engagement. What is that? That the connections between the attachment figure and the person. It is just a basic infant and parent relationship. Now we will be conceptualized what is attachment trauma. So I have conceptualized in that way. If there is any trauma, it could be single trauma, it could be multiple trauma, it could be any pattern of trauma, starting from abuse to war zone or other kind of disaster, any kind of trauma disrupts our early secure attachment style. And if that bond gets disrupted, then creates the attachment injury. And when this attachment injury is there, the person is very vulnerable. And from there, the generation of core belief that I am not lovable, I am not adorable, people don't like me, or I am not someone who is worthy. So all this generation of core belief comes from this attachment injury if we see from attachment theory perspective. Okay, it is not the CBT perspective. It is the perspective from attachment injury and the trauma connection. Next is that if this new stressors or maybe the maintenance of attachment injury, if this continues, then it again leads to the trauma. And then this vicious cycle is maintaining. These are some important terminology which are highly prevalent in this field of research. First is attachment figure. Basically, in infant, the first attachment figure is the mother. That attachment figure transmitted to the adulthood and turned into the spouse or partner or any relational support, any authority. This how the attachment figure or the attachment object transmits. Second is attachment insecurity. What is that? Say, for example, physically, the attachment figure is absent or whenever the need is there. I can give you one example, like a child always wants the, or father or mother will always go with her to attend the school or maybe some important days, some parent teachers meeting or something like that. But maybe the one parent never attends all those things, never attends any curriculum or anything. So for that kid, what is the thought? That my father is never there. My father is never there for my parent teachers meeting. Be it how bad, be it how scolding you are getting from the parent teachers meeting. It is just that there is absence of attachment figure which can create the insecurity. Okay, now we will be talking about attachment injury. It is basically there is one secure relationship and due to lack of attachment figure or the accessibility or the responsiveness, this secure attachment pattern or the bond gets disrupted. Then the attachment injury starts. Next is that post-traumatic stress injury. We talk a lot about PTSD, post-traumatic growth, lot of things, right? But how this attachment injury and post-traumatic injury is different. In case of post-traumatic injury, we experience all those symptoms like avoidance, hypervigilance, memory, disturbances, flashback. We experiences all those symptoms. So we can conceptualize in that way, maybe the more intense trauma or the multiple trauma actually collide and this forms in this way. Next is This is about the adult attachment. Okay. So if we talk about adult attachment, these are the three major areas and how it has been transmitted from parent child to friendship, romantic partnership. This how it has been transmitted. Already all these things have been discussed, but these are the important area when we reach to the adulthood. Okay. 1 minute. Prerna? Something. तो क्या करें इसका? अश्मिता देखो तो क्या होगा? ठीक है. ऊपर
यही तो किया था.
ये आगे नहीं जा रहे हैं.
पीटी इतनी तो नहीं है कहीं. पीटी इतनी तो नहीं है. कितने पेपर टोटल? चलेगा माउस. कौन सा वाला? ये
नहीं, ये ऊपर का अगर हटा देना है ना, फिर उसके बाद चीजें नहीं होगी. बता रहे हैं ना, वही बता रहे हैं. अब क्या करेंगे?
चला लो वैसे.
देख नहीं पा रहे हैं. मेरी नाटक जा रहा है. Yeah, actually it is basically vice versa. It impacts the other one and the other behavioral dysregulations again vicious life. Yes. Yes, we will discuss after the presentation, okay? Yeah. Sorry for the technical glitch. So why attachment injuries are crucial? So I have conceptualized this in that way that if there are trauma, any kind of trauma again, that lead to the attachment injury. And because of that attachment injury, we experience those trauma responses like hypervigilance,
memory problems, avoidance behavior, and the other freeze, flight, fawn, all those responses we experience because of these attachment injury. Next, when those trauma responses come to the symptomatic manifestations like the psychopathology, how depression, anxiety, dissociations, and other related disorder has been manifested. So, considering these psychopathological manifestations, and from that, when, say for example, because of this attachment injury and trauma mechanism, a person is experiencing chronic depression, and that chronic depression itself can condition the trauma factor. So again, it's a cyclical process. Both can affect each other. This is the interplay between attachment injury and trauma. These are certain factors, and we can see how it works. See, for example, we can see that amplification of traumatic events. We don't know how and to what extent the amplifications, but this impact our interpersonal relationship, especially in the adult life, and it creates a lot of emotional dysregulations, again contributing to the psychopathology, because there are a lot of disturbances in coping mechanisms and other symptoms in our body and mind, because when we talk about trauma, it is always physiological first and then it is psychological or the cognitive area. Next, this slide, I will be talking about how the caregiver attachment is connected in the early development and the adulthood development. Say, for example, we can see that caregiver with traumatic experiences, in that case, when the mother is pregnant, okay, if the mother is experiencing some psychiatric conditions, then those things are transmitted into the baby, and then it will be continued into the HP axis and the all trauma cycling process, which actually holds the that fear in the body. So whenever we experience the next situation, our body automatically gets triggered because the body has been conditioned. Maybe the mind can deny it, or maybe we can do a lot of distraction or some other techniques, but body actually reminds, like body remembers all those things. Okay, now we will be talking about in the adulthood, a person who has a caregiver with untreated trauma. In that case, more possible of PTSD, complex PTSD, and there are a lot of emotional and behavioral dysregulations. And dissociation is again one more common thing. Next, this is a model based on that emotion focused therapy, which are highly evidence based for couple attachment relationship. Okay, but we are not talking about intervention, so I'm just mentioning this model is for emotion focused therapy for the couple attachment relationship. Here we focus on the de-escalation between the couple, and then we focus on the how to solve or how to challenges those situations, and then finally reconciliation or re-engagement stages. Okay. Next is we will be talking about intergenerational transmission of trauma with two perspectives. One is how family is carrying all those things from generation to generation, and we will be seeing that how our socio-political, cultural background, because socio-demography is very important factor, we just cannot ignore it. How this thing again play a part in maintenance of intergenerational trauma. So first we can see that if we have history of trauma, then it creates dysregulation in our sympathetic nervous system, and those stress is affecting the intimate partner relationship or the other healthy attachment relationship, and from there the attachment pattern is getting affected in children and in other areas also, and then it passed through the family and family to family. Say for example, I was talking, if the mother is pregnant and going through some psychiatric condition, so the automatically the genes are passing into the baby, right? and then again the offspring. So that's how generation to generation psychopathology is being carried out. Here, the thing is that if we consider the socio-political background like poverty, deprivation, slavery, all those things, which are actually basic trauma. Okay, we talk a lot about psychological trauma, breakup and all. But if you see the poverty level, deprivations level, okay, the rural population, you will see that those are the reasons for their suicide. So those are that much potential trauma. Okay, so how they affect our behavior, biology, and how they passed into generation to generation. Because you will see that below poverty level and those socioeconomic status, generation to generation, they are just struggling for those things, but somehow they are never satisfied. They always have the question, why this thing is happening with me? Why I am not getting the facility my friend is getting? So all these are carried out. Next is there are a lot of evidence-based management. You all are already aware about all those things. It's just that DBT, EMDR, emotion focused therapy, DBT, narrative exposure therapy, and the other trauma intervention care, all those are considered as evidence-based therapy. But I would like to say before starting trauma intervention, specific trauma intervention, we would like to explore the other areas also, because if we can find the other areas which are associated with trauma, then we can this note, recognizing and addressing attachment injury and trauma is crucial for supporting individuals in their healing and recovery. Future research includes early identification and early modification to protect, heal, and enrich the traumatized children. This concept is again similar whenever we treat or we see any children. We always talk about the fast or the earlier we can assess, then we can know, and then we can plan for the early modification. These things I think we follow for all spectrum, like including developmental disability also, right? So same for here. These are my references. Thank you. Any question, feedback, suggestion, you can ask.
So in your last second slide, you mentioned ABFT. Can you please give the full form?
Oh, that is attachment-based therapy.
Thank you.
Okay, yeah. Any question? Or anyone would like to add something or contribute your experiences? I guess, okay. Can you find? Yeah, sure.
This session was actually enlightening because I was just sharing with you that I have a relationship with someone, my sister-in-law. She has gone through after caring for her father who died, and then personally experiencing widowhood all of a sudden just before after marriage, and then being let down, supposedly been let down by the other figures she thought would help her or uplift her, including her own brother and obviously my husband and his brother. So now everybody, even I had realized being a therapist that she is going through trauma, and it's all symptoms of grief which are being experienced. Is how the trauma has been repeatedly manifested in her behavior and how it has affected the interpersonal relationship she has with others. She has become more aggressive, more argumentative. She doesn't want to talk to anybody in the family. she's seeking support. It was very enlightening. Attachment
Usually
injury, I
this-
think we never focused on.
Usually this term, injury, it's a very recent term. It's coined in 2001. And this term has been like explained in terms of adult relationship and couple relationship. However, if you go by the phenomena of attachment, okay, then you can actually link with the Bowlby, Ainsworth, and the other theories.
I think
and how
father
it is-
figure
yeah.
or any adult you look up to that you
Yes.
feel will take care of you and protect you, and where that attachment relationship is, and if it is affected by let down of expectations from that person, obviously if there are expectations, you are going to feel let down.
Yes.
So that causes a big that changes your view of the world.
Yes. And one more thing is that this is some area we focus at the later end.
Yes.
When all the therapies have been failed and all everything. We never question when a child is suffering from depression since the childhood. In adult age, the child, maybe the person has been diagnosed as recurrent depressive disorder. So you can think so many depressive
I'll
episodes.
ask a personal question, ma'am. My daughter writes diary. I read her in her diary that I feel very alone. Whenever I enter the room, Mama and Bhaiya stop talking. And I was living away from my husband because he was posted at the border. So usually there were some troubles in the family, and me and my son was older, so we used to discuss, and she was a kid. So we used to stop talking. Obviously, we didn't want to burden her with the troubles that were going on or the drama that was going around. So how do I resolve that? Because I feel there is an attachment injury there.
Yeah, so in case of again if the close proximity, close family member, you cannot directly put into those efforts. But yeah, the point I was trying to focus that when there is depression or when there is other symptomatology, we focus on those symptoms. In addition, we focus on some self-growth. So we pick up some CBT along with some mindfulness-based therapies. But we never focus on the root cause, that why this depression is keep on happening, why there are a lot of relapses. Just see those areas.
That is where you need to
this is
apply
something developed from infancy, but we overlook it. We only focus when the married couples are coming to us, and then we see okay, there are certain problems. But we don't see for the friendship, for the other relationships, colleagues, anything. We don't do that.
Yes. Okay. Thank you so much, ma'am.
Thank you.
Thank you, Sneha. That was a very enlightening lecture. And I would like to thank all the participants for their such enthusiastic participation. We hope to see you all tomorrow also on time. The venue for tomorrow will be C Block Auditorium. The program will begin at 9 a.m. sharp. So we hope all of you are going to be there at 9 a.m. so that we can start on time, and we'll try and kind of finish also on time, or if possible a little early. Is there any questions anybody has? Are there any questions that anybody has? So we will be circulating all the evaluation forms which have been sent on the group chat. Please fill them up today. Today's sessions, you need to fill them up today. And for tomorrow, you need to fill the sessions evaluation tomorrow. The evaluations for today will end at 12 in the night. So try and kind of do it as quickly as possible. I hope all of you do know the rule that 70% in total is required for you to acquire the certificate and the CRE points. So kindly check your scores. The scores are given after every evaluation. Kindly check your scores. And if you think that you're not scoring enough, please be a little more attentive tomorrow. Today's sessions all encompassed understanding of trauma and what trauma entails, trauma-informed care entails. Tomorrow will be more therapeutically oriented sessions. So Please be ready with a lot of case discussions. Those of you who want to discuss those cases as well. And thank you, everybody. We see you tomorrow. Thank you.